So we will have the stomach attached only by the lesser curvature. Once we achieve this mobilization, we will make a tube-like stomach or a vertical gastrectomy using serial firing of linear staplers. But this may look anatomical in terms of what we do, but it increases the gastric emptying time, increases the intestinal transit time. Because of this, the food transits the intestine faster. So it causes minimum malabsorption. But also because of this, certain gut hormones, I do not want to get into that because that is a presentation of its own. These gut hormones get modified. They cause the effects which I mentioned to you earlier. So sleeve does not mean cutting the stomach, removing the stomach, making somebody eat less. No, because most obese patients are already eating less. The aim is not to make them eat less, but to cause an endocrine change in their body. With this understanding, I think I'll get to the surgery. We will get to the technical aspects of the surgery. If you have any questions, we can take the questions as we do the surgery. Of course, we will try to keep questions with regard to the technicalities during the surgery. Towards the end, maybe we can take questions about functioning, how sleeve works, results of sleeve in terms of outcomes, etc. can be discussed if time permits. With this, with your permission, I'll move on to the surgery.
Thank you, sir.
Outside the ports. I have already placed the ports. I will show you the port positions. So the patient is in a reverse Trendelenburg position in a leg split. I am standing in between the legs of the patient. The camera, the monitor is exactly at the head end of the patient. And the camera surgeon, Dr. Pradeep, is standing to the left of me, that is to the right side of the patient here. The liver retraction staff or the second staff nurse will be standing again on the right side of the patient towards the end. That is for liver retraction. The primary nursing assistant is on the left side of the patient, that is to the right hand of me. So that will be easily helpful to get any instruments from her to quickly get the surgery done. I have created pneumoperitoneum using a Virus needle about 5 centimeters supraumbilical and to the left of the umbilicus. Why at this point? Because that will give us me a very good view towards the hiatus. So because in an obese people, the fat around the hiatus is extremely high. When we go from the left, because that is where a primary dissection is going to be, we get a better visualization. My right hand working port is a left subcostal port, which will be angulated. These are all, only this is placed blind. Remaining are all placed under vision. The right hand working port is angulated towards the greater curvature of the stomach at the level of opposite to the incisura, because that is where we will start our dissection, proceed upwards and downwards. And a left lumbar port for counter traction, and only one 12 mm port, which is somewhere between the midline and midclavicular line, below the level of the antrum. So this will be my left hand working port, and also subsequently all my stapler firings will be through this 12 mm port, which is on my left hand. Any questions at this point?
Sir, it's clear, sir. Thank you.
Thank you, sir. So now we have the stomach, and all upper GI procedure is very important that we put a Ralph's tube, empty the stomach completely, more so importantly at the fundal area. ஆமாம் Ralph's tube கம்ப்ளீட்டாக எடுத்துட்டீங்களே வெளியில்? இங்கே ஆக்சுவலி நம்ம மேலே பண்ண மறந்துட்டோம். முடிஞ்சால் போடுங்க பார்க்கலாம், நான் அதுக்குள்ளே பண்ணிட்டு இருக்கேன். So basically they put the Ralph's tube and they've removed it. All the contents of the stomach to be reduced. Why I primarily said the fundal areas, the fundus is the most dependent part of the stomach. So some air, saliva, gastric juice might be lying in the fundus. So when we are doing the posterior dissection, there will be like a boggy fundus standing out there, which can sometimes make the dissection a little bit more difficult. So always get in a Ralph's tube in all upper GI procedures per se. Like I've just gotten the Ralph's tube. See, I'm pushing it to the fundus. Sister, now empty it, suck. It could be a fundoplication, achalasia cardia, gastrectomies, TVGJs. This technique is a very nice technique to make your surgery very easier by doing it in the beginning. So once you have done it, get out the Ralph's tube. So don't have the Ralph's tube in place, because sometimes we might forget and we will end up firing a stapler on the Ralph's tube. Remove the Ralph's tube outside, sister. Now the aim is to create a complete gastrolysis. So we'll have to be dividing the greater curvature attachments. You see the left gastroepiploic artery arcade, the right gastroepiploic arcade will be here. This is called the arc of Barkov. So the right gastroepiploic comes from here, the left gastroepiploic comes from there. Usually towards this point, they'll usually start branching out and the vessels will be slightly thinner. This is the incisura at a level opposite here. So this is probably the easier area to enter into the retrogastric space or the lesser space or the lesser sac. So this area we can use to divide the gastric omentum and to get into the retrogastric window. So with the counter traction here, I'll be using an energy source. It could be harmonic, it could be ligashore. Today I have been given a ligashore, so I'll be using a ligashore. So ligashore is an advanced bipolar system which basically coagulates with a feedback. Once the coagulation is done, it has a cutting mechanism. See, it coagulates and then cuts. Unlike in a harmonic where it uses ultrasonic shears. You see this plane open up. See, it's opened up. So you're already into the retrogastric space. Now I'll continue my gastrolysis superiorly. Try to stay closer to the stomach, not too close that way on the wall of the stomach. So the staff is giving me the traction and helping me retract the greater omentum. And we need to have a very good table which can accommodate heavy weights and also which can go, the head eye can go quite well. Because if the head up is not going quite well, fundal dissections can be sometimes, because all this greater omentum will be falling there, the surgery might become difficult. This patient is a 130 kilo, 36 BMI, 13-year-old female without any comorbidities, who's planned for a sleeve gastrectomy. We are seeing the pancreas below. Especially when you're using a harmonic, try to not to have the active blade posterior, because the active blade will get heated up. It can touch the pancreas. Not much damage can happen, but of course, very rarely some peripheral ductus can get injured. Rarely some pancreatitis have been reported. Of course, in a ligashore, there is no heat outside. The heats are within the blade, so it's okay. I am now approaching the short gastric vessels area. You spleen the splenic artery there. No. So now we are going, this is the short gastric. When you're holding the short gastrics, you should not be doing bit by bit. Hold it like how you hold a hen's neck. And more towards the stomach side. Because even if it avulses and bleeds, you have tissues on which you can apply a bipolar. So many people stop the dissection out here. No. What is important is subsequently after this point, this entire fundus needs to be released from the left crus. You are able to see one vessel here. Do you know what vessel is this? This vessel is the posterior gastric artery. This is there in almost all the cases. But of course, if you see Gray's anatomy, they reported in only 33% of the cases. This is usually a branch of the splenic. In 60% of the cases, in the remaining, it is a branch of the left gastric. We have in fact reported an article about this posterior gastric artery, how this identification and division is very important for a good sleeve gastrectomy in the obesity surgery journal. So now you see we are continuing a dissection. So the entire fundus has now been taken. Come back. So you see some physiological additions, the gastropancreatic ligaments. Even these needs to be released, because the aim is to completely dissect the fundus away. Because removing this fundus as completely is very important, both for the short term and the long term successes. And this fundus produces a hormone called ghrelin, which is an appetite hormone. Basically, when we see any food, we have the love for food and we get an appetite. That is primarily controlled by this hormone called ghrelin. So removing the fundus reduces the blood levels of ghrelin to the lowest, and hence improves the short-term outcomes. In the long-term standpoint, the fundus is the most distensible portion of the stomach. If we leave behind fundus, it can start dilating over time and can cause a failure of restriction. Okay, so you can see the left crust, all the attachments have been released completely. This is the lesser curvature. In fact, if you start going here, you can sometimes start, see, can you see it? You can even sometimes identify the left gastric, which is not needed. Now I'm moving my dissection towards the antrum. Here we do not have to go until the pylorus because our aim is not to do an antrectomy. See, antrum is not part of the reservoir of the stomach. Antrum is the antral mill. It basically helps in taking the food from the stomach towards the duodenum. So, leaving the antrum is important to preserve the stomach function. So, we will be starting our firing 5 centimeters from the pylorus. Basically, we can call it partial antrectomy. So, you see the pylorus here? So, we don't have to go until there. The antrum is almost until here. We will be starting 5 centimeters. So, we will look for 5 centimeters. Any Karl Stoll's instrument, the tip to the instrument to the K is 5. So, this is somewhere the 5 comes here. I have divided more than that. So, that should be enough. Now, I am flipping over the stomach to see if there are any physiological adhesions that needs to be released to ensure a good mobilization. I don't want to keep dissecting this more because these are protective fibers for GERD. Okay, should be enough. Now we'll be having a bougie in place, which will be a 38 French bougie. Bougie inside, give me stapler. Push, push, push. See, I'm just pushing the bougie to the antrum, getting in a stapler. I'm using an Ethicon stapler here. The antrum is the thickest portion of the stomach, so you need a large stapler. So green is the largest in a regular length. And of course, there is something called a tri-stapler technology wherein there are 3 different staple lengths. But in same sized stapler, in the regular uni-stapler mechanism, green is the largest. It has an open stapler length of 4.1 mm. Push the bougie a little bit more, enough. So knowing sleeve gastrectomy is also good even in a general practice, especially when we are encountering GIST, in large GIST in the greater curvature or sometimes in the antrum or in the fundus. You will be doing something modified to this. Of course, you don't have to do exactly sleeve gastrectomy of this kind, but it will be actually a modification of a sleeve gastrectomy. Usually, we don't go too snug on the bougie at the level of the incisura because the incisura is an area where the stomach angulates, it becomes an L. If you are too close to the bougie and then fire it, subsequently what can happen when the stomach turns, it gets narrowed down. And this gets narrowed, it forms a stricture. And this stricture can cause upward dilatation and also can precipitate a leak in the proximal part of the sleeve. So usually at this fire, we stay slightly away from the bougie, as you can see here. The bougie is here, about 0.5 centimeters I'm away. Same thing posteriorly also. You can see some adhesions which can be released if needed. I am now firing slowly. Usually we wait for about 30 seconds or 15 seconds is good enough before we fire. Clip ready. You see the beefs are very well formed. There is no standing out because that beef formation is very important to holding the tissues together. In case I had applied a smaller stapler, let's say white, you would not see the beef forming well. It will be standing like a Tamil pa. Yeah. Tamil, the word pa. So basically it will be just pricking. The bee hasn't formed because the length wasn't adequate. Now I'm going one step smaller. As I'm moving upward, I'm still moving one step smaller. This is a golden color, which is a 3.8 mm open length. This stomach is actually not that thick. So even a blue with a 3.5 mm is usually good enough. But as a routine protocol, we follow here green, gold, and then we continue blues. So they have just taken the gold as a routine thing. But technically in this patient, the blue also should be good enough. So the green from Ethicon is 4.1 mm open stapler height. But in Medtronics, the green would actually be a 4.8 mm, which is a much bigger stapler. Why that is bigger and this is smaller is, if you need a 4.8 mm, then we will need a 15 mm trocar. The gun is bigger. Sorry, stapler is bigger. But with the 4.1, we can accommodate the stapler using the 12 mm trocar itself. We don't have to go to a bigger trocar. So that is one advantage. But if the stomach is extremely thick, then a 4.8 mm is better. Blues. As we continue, we need to check for any staplers that are hanging out, what we call the crotch. There's nothing like that, because if they're hanging out, you need to remove it, because if they are caught there, then the subsequent stapler filings can get misfired. So you see 3 staplers being fired on either sides, or 3 rows. Now I'm going to a blue. See, my stapler is completely oriented towards away from the G junction. Because many people do their sleeve gastrectomy, the first 1 or 2 fires from the left hand, then subsequent fires from my right hand. Can you see my instrument moving this kind of a direction? So my stapler will be in this angle. Easily we can misfire on the OG junction or onto the esophagus. So that causes a leak, the chances of leak to increase. So using it in my left hand, I'm staying away anatomically, or the orientation itself is staying away from the esophagus, because we'll be continuing a fire. This is the OG junction here that you can see, which we have mobilized 0.5 centimeters away from the, this is the direction that we want. We don't want to go to the OG junction or here, because here it is esophagus starts. The vascularity is poor, it can leak. I was talking to you about the crotch, right? Can you see? This is that crotch. I have now removed it. And if the orientation is done well, if the posterior dissection was not done well, I might end up taking more of the anterior wall and less of the posterior wall. Sorry, less of the anterior wall and more of the posterior wall. So you'll see the staplers to be hanging in the anteriorly, or the other ways it can go posteriorly. The sleeve, for the motor function to be well preserved, the anterior and the posterior wall have to be equal to each other. So the stapler line should be as lateral as you can see, a flat lateral line, which means the walls are equal. Otherwise, what happens is it becomes like a zigzag kind of a stapler line, what we call the corkscrew stomach. Similar to what you know of the corkscrew esophagus, right? The motility gets altered. So the lumen size will be good, but the patient will constantly come with dysphagia, vomiting, etc. You do an endoscopy, it will look normal. But when you do a barium swallow, it will show a kind of an abnormal emptying. See, can you see the OG junction? I am saying slightly away from the OG junction. In fact, in a sleeve gastrectomy, this might look like a simple reproducible procedure, but the most dreaded complication of a sleeve is a sleeve leak. And sleeve leak almost always happens here, because this is a watershed zone. The blood supply from this side is not that great, and the stomach pressure, compared to a stomach, the pressure increases by about 30 to 40% in a sleeve gastrectomy. So the pressure now becomes higher. Vascularity is also low. So it is not the stapler misfire, but it may not heal well, and the leak happens after 3 days, more like a duodenal blowout. So that is why this area is the most riskiest area. Leak can happen even the easiest of the cases. We do not know who will leak and who will not leak. So in GEM, we do a routine step where we plicate and imbricate the top end of the stapler line to prevent this leak from happening. I will need one more fire definitely. And also when you are firing, we need to try to avoid a dog ear. Let's say I fire like this. this will become a kind of a dog ear. Automatically, that will have a poor vascularity. So we need to avoid a dog ear or any acute angle at the top end. So simple maneuver that can help us do it is pull this one down. Then when I fire like this, then the angle now becomes more obtuse than becoming up. After I fire, you'll be able to understand. My stapler line will be more like that, not like it creating a dog ear. See, you don't see a dog ear there. You see, because now what has happened, stapler line is coming like that and going like that. So you don't see any dog ear at all. See, there's absolutely no dog ear. But however, to make sure we do not have even a possibility of a leak, we plicate and imbricate the top 5 centimeters of stapler line, which is where leak almost always happens. This plicate பண்ணு. இதை கொடுத்துருக்கிற மேரிலேருந்து இதில் தான் கொடுப்பீங்க. இது எவ்வளோ பெருசு? 30 சென்டிமீட்டர். இது அப்சர்வ். So we have a barbed PDS from Lotus. இதுக்கு பேர் என்ன? Barbie. It's called the Barbie. I always know it carries that toy's name, but I always forget it. This I will not be doing to the entire length, only the top 5, because leaks almost always happens only there. This might look like a nice sleeve, we have done quite well, but we never take chances. And almost all high volume centers have started doing something of this kind. So you will be trying to understand, I'll be initially plicating it. Barbed sutures have become a revolution since the introduction a few years back. So it will be kind of a modified lembered suture. So I'm just fixing it above the stapler line. Then you'll see that corner getting buried. Now after this, we will take a bite on the omentum. Something like a modified Graham's patch. Take principles from other general surgeries and you can find. So we're just initially fixing this. So this first step is basically burying the corner and then fixing the omentum. Subsequent steps will be slightly different. We'll be taking a bite on the omentum, which is the policeman of the abdomen. Then we take on the posterior wall. Then we take on the anterior side. So the stomach will get imbricated, the stapler line will get imbricated, and we are transfixing the omentum. So technically, even if a leak is going to happen, we have done already what is supposed to have been done later. Because later when we come into it, it will not take up because it will be inflamed tissue. So we have started doing this for the last 8 years or so. And touch wood, we have not had any leaks since then. Many questions could be, why not below? This is not because of a stapler line misfire that it can happen. It is the healing effects. Because the staplers, once the introduction of these staplers have been a revolution in preventing leaks. But then these are not stapler misfire issues, because stapler misfire I know now only. So that is why we are not doing it below, because usually the leak does not happen. If you take literature and see, almost all sleeve leaks that have been reported would be from this area. So with this we should be enough. We stop. Scissor. BP nerke? What is the baseline BP?
Any question from the floor? We put to the operator.
Yes, sir, please.
Praveen, you are continuing the same till the pylorus?
No, sir. I've stopped it. I've done.
Ah,
Only the top 5 centimeters we do it, sir, to prevent leaks. Because leaks never happen below. Leaks almost always happens there. And we do not know who leaks and who does not leak. So only the top 5 centimeters we do, sir. We don't continue this below.
Is there any chance for internal herniation at the top after this bite?
Sir, through this, sir, bowel cannot reach here at all, no, sir, because this is complete in the supracolic compartment. Come down. So you have the colon here and the omentum here. So no intestine can really come up. There is no defect for the intestine to come to the supracolic compartment. And only then it has to, only if it can come to supracolic, then it can herniate. And still, sir, this is such a big space. It's not like it's quite a wide area as such. So no herniation can happen through this window, sir. And even if we don't do this, sir, naturally this omentum will start sticking. I think over time you will see when we come for a revision, this entire part of the stapler line will actually have physiological adhesions form. Even if I am not going to close this, adhesions will automatically form. We do not want in the first 3 days for a leak to happen and then omentum to come and seal. We have already sealed it, sir. That's all. Anyway, natural adhesions will form on its own.
Any other question from the floor, sir?
Please. You want to put the speaker? I mean, operator? Come sit here.
Sir, good morning, sir.
Yes, sir. Good morning.
What is the chance of hiatus hernia in post-operative, sir?
Sir, in a sleeve per se, it's not hiatus hernia, but if you actually have to say, because we are dividing part of the phrenoesophageal attachments, at least on the left side completely, good number of patients, you will see the OG junction, not really like a hiatus hernia, but you see the hiatus, the OG junction move into the hiatus. So when we do a lot of revisional surgeries, we actually go and find the OG junction into the hiatus only. This happens in most of the sleeves. That is why we call sleeve as a refluxogenic procedure. Because what happens, sleeve increases the pressure, and also we're dividing the phrenoesophageal attachments to partly, so there can be some mild hiatal migration causing reflux. So that is why any patients with mild to moderate GERD or of course severe GERD, sleeve is a relative contraindication. We don't do sleeve at all. In those patients, we do a gastric bypass. And if post sleeve, they develop a large hiatus hernia or they develop severe GERD, Roux-en-Y gastric bypass is the treatment of choice. But the chances are very low, requiring a surgery per se, but the hiatal migration is quite common. In fact, this patient also, we had done a pH impedance study to know, because this patient had minimum GERD symptoms. We did a pH impedance study to know what was the Demister score before we are going ahead with the sleeve. The Demister score was normal, and that is why we're doing a sleeve. In case it was higher, we would have done a gastric bypass. Of course, patient being willing for it.
You put a bougie now. What is the size of bougie and what should be, on what factor you are deciding the size of bougie?
So there is one single size, sir. With regard to evidence, it is said of a standard sleeve should contain any size between 36 to 40. This is a 38 French gastric calibration tube from Johnson & Johnson. It comes with one single size. But of course, we are not using this gastric calibration tube in case we are using the esophageal dilators. Anything between 36, 38 or 40 should be fine, sir. Anything lesser is too narrow, anything more is too big.
Are you going to do any leak test now?
No, sir, I will not be doing any leak test, sir, because the stapler line are very obvious. B formations are excellent. I have closed on the top. So in a sleeve gastrectomy, we don't do a leak test, sir, because again, it is not wrong to do, but then when everything is under vision, you don't really find anything in a leak test per se, sir.
If at
So
all
I
you
will
want
not
to
be
do,
doing it.
if at all you want to do, what you prefer?
So
Methylene blue or
normally
something?
for any anastomotic like gastric bypasses, we do leak test, sir. We do the air saline test. Of course, this is my preference or gem preference, I would say. But a lot of surgeons outside do methylene blue test. But again, from regard to the bariatric community, leak test for a sleeve gastrectomy is almost stopped. And lot of surgeons do not do leak test even for a gastric bypass. However, I have been doing and we have been doing for gastric bypasses, but that too many people have stopped. And again, air saline test and methylene blue test are equally sensitive to each other. So I think anything is fine in case we are doing it.
Any question from the floor? I think. Sir?
So since you spoke about that internal hernia, because you asked me a hernia, I'll probably show you this. If you can see here, this is the mesocolon here. You can actually see the intestine below, the DJ flexure here. Many times when we are doing a sleeve gastrectomy, if we accidentally open off this, this can become a potential site of a mesocolic hernia or an internal hernia. Then if we identify that, that needs to be repaired. Here in this case, we have preserved it. You see it, sir, it is not there. So we have done it. But sometimes this can get opened up. If we are picking it up, that needs to be closed. This can be a site of potential hernia in the future.
Of course, chances are very less because you nicely elevated the both stomach, no?
Yes, sir.
So the chance for puncturing the mesocolon is very, very rare.
Yes, sir.
Correct.
Yes, sir. பூஜி எடுத்துலாமா அது நல்லா இருக்கும் அப்புறம் பண்ண முடியாது. So we'll be checking for bleeding. So before we check for hemostasis, it is always important that we make sure that the BP is higher than the baseline BP, because this is a high pressure system. Bleeding can happen post-operatively. So increase the BP. We should not get carried away with stapler line looking good and go away, because sometimes the BPs are low. Anesthetists are very happy. We close down and then it can have some bleeding post-operatively. Now the BP is 140/90. The baseline was around 120s, 80s. We increase the BP, we check for hemostasis, we are happy, so we have removed the bougie. And the clips that I have applied or on any points that I saw bleeding or intersection points of staplers, those areas clips are good enough. And of course, applying clips, it is always easy when the bougie applying the clips and the bougie is there. Because now if I want to apply clips, it's much more difficult. Of course, we remove the bougie, check for hemostasis once again. See, there is a small bleeding site here, couple of points in fact. Probably this started happening as the BP started to raise. And many times when the bougie is snug, what happens, because of the pressure, bleeding may not come out. And once you remove the bougie, you start seeing it. But this I feel because of the BP rise.
Should we take additional sutures as a bleeding point?
Not really not needed as such, sir. Clips are pretty good enough, sir.
Pretty good.
Yes, sir. Probably the BP is going up even further than what we wanted, so that is why it's happening. Even like sometimes pulsatile bleeders that you see, sir. On the earlier, when I started my career, we used to put all the figure of 8 kind of a sutures, sir. But the clips are usually good enough, because after a point the vessels get thrombosed also. So rarely, even if the clips fall, they don't really continue to bleed. And adhesions will form, sir. In fact, these omental adhesions start forming in about 24 hours itself, sir. Because these are raw area and the omentum wants to go and get adhered. One more. Any other questions, sir? Before Prabhakar, Artha case ready, Arka?
Praveen, you know how many people are watching your wonderful surgery? Can you
Sir,
guess?
please, sir, I'm not sure.
Nearly about 50 surgeons are watching your wonderful procedure. Beautifully demonstrated. Beautifully demonstrated.
Thank you,
Thank
sir.
you,
Thank you, sir.
Praveen, can you hear the claps?
Yeah, sir. Very well, sir. I heard it really well. Thank you, sir.
In fact, you have taken time even less than for a hernia surgery. Can I take it like that? Absolutely. Wonderful. So there's a point to say reaching the unreached. That is, it was very, very difficult. Kumbakonam is quite far off from Coimbatore, but you made the concept and the surgical technique reach Coimbatore from Coimbatore to Kumbakonam. Wonderful. Wonderful. Congratulations, Prabha.
Thank you, sir. Thank you, sir. Thank you, sir. And my best wishes to everyone out there, sir. I'll see you sometime, everyone in person. And thanks to the entire organizing team once again for this invitation today to be amongst all of you. And then I'm sure you'll have a very nice day. And we have the other case that is ready, which Dr. Parthasarathi will
Praveen,
be starting.
Praveen,
Yes, sir.
one Dr. Bharati Dasan from Karaikal. He is a professor of surgery. He wants to put a couple of questions to you, please.
Sure, sir. Sure, sure.
Rather appreciation, I should say.
Oh, okay, sir.
Good morning, sir. I am Dr. Baridasan.
Yes, sir. Please, sir.
Sir, really, you showed a very wonderful procedure, sir. We are
Thank you, sir.
mesmerized by your procedure, sir. Thank you, sir.
Thank you, sir. Thank you, sir.
Praveen, we are all spellbound actually by your fast and fast. Actually, it is a very delicate execution of a wonderful procedure. Dr. Silvam from Mailadure wants to talk to you.
Yes, sir.
Good morning, Praveen.
Sir, good morning, sir. How are you, sir?
Fine, sir. The surgical work was very excellent.
Thank you, sir.
Okay. Congratulations.
Thank you, sir. Thank you, sir. See you sometime in person, sir.
Praveen, everybody wants to congratulate you, but we thought we will restrict to a couple of two. Okay, yeah.
Kandipa, sir. Sure, sir. Sure, sir.
Yes, sir. Because
I think we can move to the other theater, sir.
yeah, certainly. Yeah. We are looking for the
Sure,
next
sir.
case.
Thank you, sir. Thank you, sir. See you all, sir. Bye.
Anybody in the floor doing any bariatric procedures, sir? They can give their comments. I think from today you can start doing, isn't it? How many of you are doing laparoscopy? Almost everybody, no? Isn't it? So from the way in which the surgery was demonstrated, it looks very, very simple and everybody can start practicing. Only the choice of the case is very, very important. And anesthesia for the obese with high BMI rate, that is only with a good post-operative follow-up. Otherwise, the wonderful, these are called restrictive, resective procedures where you remove the portion of the stomach. They got a very good result when compared with the other procedures for obesity surgery. Sir, we have a comment on for youngsters who are coming up. Please. You have a suggestion for a laparoscopy, sir?
No, laparoscopy is a wonderful technique. But in our setup, I'm working in the Televersity Medical College. Even though I graduated in the post-graduation, postdoctoral fellowship in MMC, the chances of the instruments, patients are available, so many patients are available. But the chances of instruments, the stabilization, post-operative care, everything we are not able to get. So we are not able to progress and we are not able to apply the what we are learning from our institution. So from our work, we request our government to improve the infrastructures, to improve the instruments, sterilization techniques. Even though we are able to do the hernia surgery, but the post-operative infection rate is very high. So we are not able to progress to the ETEP or some other advanced techniques. So my kind request is the youngsters, you go through the proper technique from the proper institutions and you have to rely on the instruments and everything. Then only you will be able to do all these advanced procedures. So without the advancements and the instruments and everything, we cannot progress. Even though it looks like a simple procedure, but they have so many instruments, so many infrastructures, but we have to develop all these in our town. Then only we will be able to do. But in near future, I hope you all get all these facilities. Thank you.
after 2 or 3 decades, I think laparoscopy started in 1992, 93. Professor Udwadi, I think you know very well. Udwadi is the first person to do laparoscopy cystectomy in India. I think 1992, if you remember correct. My good association with Dr. Selvaraj goes from 95-96, wherein we used to meet in most of the laparoscopy conferences. The first laparoscopy conference was held in Delhi. It is called when the IAGES was started. So from that day, in most of the conferences we used to meet. At that time, we did not have any much guidance with regard to the course, with regard to the instrumentation that's available and resources, all those things. But now we got wonderful courses being run by so many organizations. IAG is doing and Amasi they are also doing. So a lot of people have come with wonderful courses. For postgraduates, it's very, very important you should get trained during your curriculum itself. Very nice. Okay. I think next agenda is President Dr. Prabha is going to announce regarding election of the new set of officers.
அனைவருக்கும் மிகவும் நன்றி தெரிவித்துள்ளேன். டெல்டா ஏஎஸ்ஐ ஃபார்ம் பண்ணி சார் வந்து அசாம் போய் got a special order and Delta ASI was formed the ASI Assam ASI country. அதுக்கப்புறம் வந்து கோவிட் அஸ்காம் ஒரு கிக் ஸ்டார்ட் பண்ணது கொஞ்சம் கஷ்டமா இருந்தது. But with all help of our seniors and other people, with all cooperation, we started our Delta ASI branch with my teammates, Dr. Bhavi and Rajesh Sedupati Treasurer. I think எங்கள் கனியூர் வந்து சின்ன குழந்தையா இருந்தது வளர்த்து கொண்டாந்து எல்கேஜி ஆகி சேர்த்து கொடுத்துருக்கோம். இன்னும் பெருசாகி நல்ல பெரிய பெரிய லெவலுக்கு வரணும்ட்டு விஷ் பண்ணிக்கிறேன். தேங்க்யூ ஆல். தேங்க்யூ ஆல் ஃபார் யுவர் கோஆபரேஷன் ஃபார் த பாஸ்ட் 2 years. தேங்க்யூ.
அனைவருக்கும் வணக்கம். டெல்டா ஏஎஸ்ஐ செல்வராஜ் சாரோட முழு முயற்சின்னு சொல்லலாம். ஃபுல்லாக அதுக்காக நிறைய பேருக்கு சார் பர்சனலாக டைம் ஒதுக்கி கால் பண்ணி எல்லா நம்பரையும் கனெக்ட் பண்ணி எல்லாரும் ஏஎஸ்ஐ புதுசாக மெம்பரை ஜாயின் பண்ண வச்சு ஆரம்பித்தாங்க. அதே மாதிரி கோவிட் தான் கொஞ்சம் லேக் ஆனிச்சு. அதுக்கப்புறம் நம்ம ஒரு ஸ்டேட் மீட்டிங் நடத்தி முடிச்சிட்டோம். ரொம்ப நல்லாவே நடத்தி முடிச்சிருந்தோம். அது வந்து எல்லாரோட கோஆபரேஷனும். தேங்க்யூ. அடுத்த டீம் அதை நல்லபடியாக கொண்டு போகணும். தேங்க்யூ.
குட் மார்னிங். ஏஎஸ்ஐ டெல்டா 2018 நினைக்கிறேன் ஆச்சு. ஒரு நல்ல இது நம்ம விண்டர்ஸுக்கான நல்ல ஒரு இது அது எஃபர்ட்ஸ் வந்து பிரபார் சார் தான். என்னோட ரோல்லாம் அது ரொம்ப கம்மி. செல்வராஜ் சார் தான் எனக்கு வந்து ஃபர்ஸ்ட் தடவை சொல்லி ட்ரெஷரர் போஸ்ட் எடுத்துங்க அப்படின்னாங்க. ஸோ இது வந்து அடுத்த லெவலுக்கு கொண்டு போகணும். அதனால் எல்லாரோட சப்போர்ட்டு நம்ம பார்ட்டிசிபேஷனுங்கிறது ரொம்ப அடுத்த ஃபியூச்சர் டேஸ்ல நல்லா இருக்கணும். தேங்க்யூ.
As a process of democratic process in the ASI.
I think the wonderful job done by the previous team, Dr. Prabhakar, on behalf of ASI, I thought I should appreciate the wonderful job we have done by putting by adorning a shawl on each one of you, please. Okay.
Light.
முக்கியமா அப்ரிஷியேட் பண்ணது கிங் மேக்கர் இல்லையா? Let us start the song with Dr. Selvaraj sir. இதை பார்த்தவங்க எல்லாத்துக்கும் வந்திருக்கணும். இந்த மாதிரி நிறைய நாங்களும் வாங்கணும் இந்த ஃபியூச்சர் அப்படின்னு. கரெக்டா? They are going to announce the elections for the next set of office bearers. இது கடும் போட்டி வரும்னு நினைக்கிறேன். கரெக்டா?
I request Dr. Selvaraj sir to be an election officer and call for the nomination.
So, I respected President of Tamil Nadu ASI, a close friend, Dr. Sundararajan, respected senior members and my dear friends. It is a very great opportunity for me to conduct the election process here. Thanks for the office bearers for giving me this opportunity. And I congratulate and appreciate all the work done in the previous 2 years by Dr. Prabhakaran, Dr. Bharadhasan, and the Kumaran. They did an extremely good job, and they need a very good applause. Really, they need a very good applause. And they have done a wonderful job, and they got the best prize also last year in mid-AC count. And I am conducting and I am conferring for the election. Anybody is want to contest? Already there have been few applications for each one post. Anybody want to contest for the post of chairman, secretary, treasurer, executive members? You can. Already we have received a few nominations. If there is no nominations, I like to announce the results.
ஹெல்ப் பண்ணுங்க. எல்லா போஸ்டும் வரும் இல்லையா?
So for the post of the chairman of this incoming years 2025, Dr. K. Shanmugam from Tiruvallur has given the application. He is declared as elected as the chairman of this year. And I request you to come to the election. He is a senior most surgeon, plastic surgeon, wonderful surgeon. And he has got, I think he has got very good innovations and ideas to develop the AS. Sir, for the post of treasurer, Dr. Anish Sundar Narayan, he is being declared as elected as a treasurer for this year. For the post of executive members, Dr. Selvam from Mayiladurai, Professor Bharadhasan from Karaikal, and Vijay Anand from Kumbakonam, they are being elected as executive members
And I have received the application from Dr. Nemudullah for the post of secretary, and he has not come. Nemudullah. Sir, one minute. Wait, sir, wait. Hold on. ಇಲ್ಲ ಒಂದು அவ்வளோதான் வந்த பிறகு போட்டு வந்தோன்னு போட்டா பிரபாகரன் இல்லை சார் இருக்கு சார் போட்டு இல்லை நான் போட்டு பத்துல தான் எடுத்துக்கலாம் Thank you very much. Thank you all.
புதிதாக தேர்ந்தெடுக்கப்பட்ட நிர்வாகிகள் அனைவருக்கும் ஏஎஸ்ஐ தமிழ்நாடு சார்பாக என்னுடைய வாழ்த்துக்களை தெரிவித்துக் கொண்டேன். உங்களுடைய பணியில சிறக்கம். இன்னைக்கெல்லாம் இவர் அடிக்கடி உங்க வீட்டுக்கு நான் வர மாதிரி ஏற்பாடு பண்ணுங்க. I want to come and visit. Wonderful Kumbhavan branch. Thank you.
ஓட்டி கனெக்ஷன் கொடுக்கல கட் பண்ணிட்டீங்களா?
இல்லை சார் நான் வரல
கேட்டு
They are going to start the session. The next session will be done by Dr. Parthasarathi on hernia, ETEP procedure. It will be started within 2 minutes.
I'm sure you all very well aware. National president-elect, vice president and post elections have been started. Later the nominations have been received. I think you will see each member will have received a link through which you can now vote. Dr. Mardupani from HOD of HODM Dean of Mother India College is contesting. We are all supporting and working with him on the மறக்காம ஒரு 10 நிமிஷம் செலவு பண்ணீங்கன்னா போதும். இட்ஸ் an online voting through you can follow the link. எல்லா டீடைலா பிரசிடென்ட் சார் சொல்லியிருக்காங்க. Please follow and make him successful as a national president. ஒரு 17 வருஷத்துக்கு பிறகு தமிழ்நாட்டுக்கு ஒரு வாய்ப்பு கிடைச்சிருக்கீங்க. அதை நம்ம we should make the best use of it and show how powerful is Tamil Nadu in national arena. Thank you. This is my humble request to each and every one. PGs, what about PGs? Do you all have become AIC members? Have you? I think you are associated members. Correct? Correct. But associate members are not eligible to vote. Now, once you finish your post-graduation, you can submit your post-graduate certificate and get it regularized. Even specialty branch, you are basically members of ASI. Please follow me. Please take this message to all your friends. Because நிறைய பேர் வந்து முடிஞ்ச உடனே சூப்பர் ஸ்பெஷாலிட்டி போயிட்டு தேவையில்லை சொல்லுவாங்க. Please keep it in mind that you are eligible to become super special branch இருக்கலாம், தப்பில்லை. But you are basically your ASI members. Convey this message to each and every one.
கமிங் சாட்டர்டே சண்டே வந்து தஞ்சாவூர்ல பீப்புள் மெடிக்கல் லீகல் கான்க்ளேவ் இருக்கு. எல்லாரும் மறக்காம வந்துருங்க. Those who are not registered, contact Mr. Arun Balaji for registration. Balaji, people is common to the
40-year-old male. It's a case of 40-year-old male.
Welcome, sir.
So this is a case of 40-year-old male presented with the complaints of supraumbilical swelling for a 6-month duration, and he was having occasional irreducibility and previous history. He had a previous umbilical hernia repair for obstructed umbilical hernia, open repair, and followed by laparotomy for small intestinal perforation, for which resection and anastomosis has been done. On examination, there was a long transverse scar below the umbilicus region and 5 centimeter defect in the supraumbilical region with small intestine as content. So diagnosis was recurrent ventral hernia, M3W2 type.
Sir, good afternoon, sir. Hello? Hello?
Good afternoon, sir. Yeah, sir.
Good afternoon, sir. Good afternoon, sir. Welcome, sir. Sir, on behalf of Delta ASI, we all profoundly thank you for all your help, sir.
Oh, thank you, sir. Thank you so much. Sorry for the delay. I thought Praveen finished so fast, and we are also setting up the things, transmission in another OT, another OT. So we are taking a little bit time, and now just I am showing in a laparoscopic view. This patient had 2 surgeries, one for umbilical hernia, and you can see here the scar is there. They remove the umbilicus. You can see this is a big scar here, here, and followed by laparotomy also done, and the CT is showing around 5 into 3.6 centimeter lesion, and so almost with divarication also. So I'm planning for E-tip for this patient. Okay. So all of you know about the concept of E-tip. So I'm just starting from here. This is the xiphoid process, and you can see this is the costal margin, and I'm feeling the symphysis pubis here, and here the antesuppiliac spine. Okay,
I
and roughly
request
I'm expecting.
Dr. Bharadas and Dr. Rajapur to come and chair the session.
Yeah, okay. Welcome, sir.
Dr. Bharadas, Professor of Surgery from Thorikal Medical College. Dr. Rajappa is a laparoscopic surgeon from Pudaur Medical College, sir.
Okay, sir. Okay. So welcome, sir.
Good morning, sir. Good morning, sir.
Yeah, good morning. Good morning. Are you able to see the view, sir? Abdomen view?
Yes, sir. Yes, sir. We can see, sir.
Yeah, yeah. Okay. So I'm showing it in this direction, and you can see here it is a symphysis, xiphoid, symphysis pubis, and then roughly I'm drawing the line of linear semilunaris line, and so the patient had a divarication, big divarication, and then rectus muscle, divarication up to like this, around 10 centimeter, then rectus muscle, so that linea will be here, linea semilunaris. So I'm going to start. The patient had a supraumbilical defect, and it is not well. It is like a wide defect, sir. It is not coming out much, and it's a wide defect. So anyway. The mesh will have come up to this level. So I'm going little higher up here. So since divarication is there, I'm going little laterally. If it is divarication is not there, you can around 2 finger breadth from midline enough. So now I'm going 3 finger breadth from the midline. So entry into the retrorectus plane, we have to enter the retrorectus plane, and I'm using the opti view trocar, external view coming, full screen photo. So this is the 0-degree scope, and then I'm introducing into the opti view trocar. Can you see, sir?
Yes, sir. Yes, sir. We can see.
Yeah. Good. Knife, good. So make it 11 mm trocar, make it little big incision or 12 mm, so that the entry will be easier. And now you can see laparoscopic view. Are you getting laparoscopic view? Yeah.
Yes, sir. We can see.
Okay, sir. So this is now you can see the external. Usually what we do, usually they hold the camera, they rotate the trocar, and sometimes they, along with the entire unit, they rotate like this. That is wrong actually. You can see the image should not be rotated like this. So I'm keeping the camera static, and then my instrument is vertically placed. I'm keeping it very vertical, and you can see I'm rotating only the trocar. Can you appreciate, sir? Image is not rotated, only the trocar. Now you can see subcutaneous, and then center will be the white color structure. That is a linea alba, anterectus sheath. So I'm piercing the anterectus sheath now, and you can see the muscle is visible. Gas connect panna. On. So now I'm connect gas is connected. Now you can see I'm piercing the muscle. I'm piercing the muscle. The anterectus sheath is well seen, and then muscle also pierced. Now you can see the center is the post-rectus sheath. Once I see the post-rectus sheath, then I turn. Now if I see the external view, my scope, not trocar and scope, will be turned towards pelvis, obliquely. Obliquely I turn, and then I'm just pushing the trocar. I'm pushing the trocar. See, just pushing it inside. I'm not rotating. Once I see the post-rectus sheath, I'm not rotating. I'm just pushing the trocar. Now you can see, sir, this is the retrorectus plane. Now you can see, I'm just dissecting with the telescope. And I'm trying to push this layer up. Push this layer up. I'm trying to push this layer up. Clean. Can you see, sir, laparoscopic view?
Yes, sir, we can see
Yeah.
nicely.
So this is the technique. This first done by Palnivelu sir, and we are following here. See, usually, people will still they are doing a open technique to enter this space. So open technique means, incision will be bigger, and here you can see only the trocar site, trocar size. We are making the incision, and then we can enter very easily. Even in a obese patient, this is a very good technique. So safe, and then we don't miss the findings. So very fast also. So now I'm dissecting. So where the vessel is there, I'm avoiding that. Without a vessel is not there, that place I'm dissecting it. So I'm dissecting laterally in the upper abdomen. Just you can see it in the external view. You will able to find out. I'm dissecting lateral side. Usually I do E-tape for a elderly patient, obese patient, and recurrent abdomen, my recurrent fistula, my technique is E-tape. My routine practice is E-tape. So now I dissected laterally, sir. Now you can see the bundle. This is the one neurovascular bundle. I'm going laterally, and that is a linear seminoris. Now you can see the posteriorly the muscle, that is a TA muscle, transverse abdominis muscle. That is another linear, this one neurovascular bundle. This is the one neurovascular bundle. So every 2 to 3 centimeter, we used to get one neurovascular bundle. So this much space I dissected. Clean. So I'm going to make another trocar. Even if external view, you can see little bit bulge on the left retrorectus plane. So I'm going to make a trocar here. Because of this vessel, I'm just going deeper. Hold this. So almost what the line I made, it is looks same. I'm making first 5 mm. Any questions or any doubt? And here you can introduce the LP needle because it is sometimes the control will not be there. So that's why you can introduce the LP needle and then you can make the trocar. Or I use directly introduce the trocar, but only thing you should not injure the neurovascular bundle. And you can use any energy device, even monopolar or bipolar. And since I have here ligature, I'm using it. If you don't want to use ligature, tell me. I'm doing with only with monopolar and bipolar. Even hook is enough. Hook How is the clarity, sir? Vision?
It is clear, sir. It is clear.
Very clear. Okay. Hook sister. So I'm using a hook monopolar. Any doubt regarding technique or procedure wise concept? Everybody is agreed about E-tape nowadays. But still, no, IPOM plays the major role in treating ventral hernias. But ETAP is coming up. Or you see, sir, I'm leaving the preserving one layer covering the muscle. So that is a very important one. No, because we don't want to the miss direct contact to the muscle.
Okay.
Now it is not possible in all cases. As much as possible, we are preserving that layer. Pressure maintain ஆகுதா பாரு. ஏன் 10 இருக்கு 12 வச்சோம்ல.
What is the pressure you are maintaining, sir?
So now I'm at 12, sir. Always all extraparietal hernia, I used to keep 12. 12 is the ideal pressure. If you go more than that, what happen? Gas they will dissect more. So extra some subcutaneous air, no surgical emphysema will be there. That's why always not 12 is ideal. You can see the another neurovascular bundle here. So all the neurovascular bundle to be preserved. So we are not injuring any structure in E-tip. Only thing the post-rectus sheath is we are dividing from linea alba and then we are suturing it. So that's why nowadays the hernia repair is called a functional hernia repair. We are trying to preserve the muscle medially, preserve all the neurovascular bundle and then bring the rectus muscle medial so that rectus function will be normal and patient can do forward bending and then they can sit, get up, everything will possible. Even in a large hernia also, the technique is same. So I'm going down and that is the epigastric vessel, that is the epigastric vessel, left epigastric vessel. Here, because of the scar, post-wall rectus sheath is adherent, so that's why I leave that area. And sometimes if I open means I can enter, I will enter into the peritoneal cavity. So after I am placing the another trocar, so it will be ideal to open this, dissect that area. So I'm going to make another trocar here, and it should not injure the epigastric vessel.
Okay.
Close up, close up. Close up. Very small space because of the scar. Okay. Put 5 mm. Put. Instrument put. Instrument is the put some. Space ரொம்ப கம்மியா. இங்க வா. Show me this locker. So initially I made this trocar 5 mm. Now I am converting into 10 mm because initially there is a very less space, so that I made a 5 mm, so easy to enter. So now it is I dissected little bit space. This lensman port. இங்க வாடா இங்க வாடா இங்க தான் இருக்கு. Okay, come here. So now I am going to change to 30 degree. So after changing the trocar, I will show the changing the lens. I am showing the trocar position. Lens kudu takun. இன்னொரு தடவை வாஷ் பண்ண சொல்றேன். இன்னொரு trocar எடுத்து ரெடியா வச்சிருக்கணும்ல, நீ பார்க்கல. இது எதுக்கு எடுக்கிற, அதெல்லாம் யூஸ் பண்ண மாட்டேன். எது பண்ணுறோமோ அது ஃபஸ்ட்டு ஒயிட் பேலன்ஸ் போடுறதுக்கு ரெடி ஆகிக்க டக்குன்னு. க்ளீன் பார்த்தாச்சுடா, க்ளீன் பண்ண. So now I'm showing all these. Now external view full screen port first. Lap. Okay. Can you see, sir, abdomen?
Yes,
so
sir.
This is the first trocar I made. This is a subcostal. Focus பண்றா. Okay. பிடிச்சுக்க trocar எல்லாம் லென்ஸை பிடி. Okay. So this is the first trocar I made. Then and I made this trocar 5 millimeter, and then I dissected. I made another 5 millimeter, and I went up to this level. Still, I'm not reaching the bone. So now I converted into this. So what is this? With this view, I'm going to make another trocar. Most of the time, I use this one to cross the midline. Camera here, this two working. So nowadays we are making another 5 mm here, so that it is easy for triangulation. Is we will give this is the working, this one and this one will be this is the camera, these two will be working, so that the no dissection and the midline cross will be easier. Clean. So legacy report. ஒன்றும் தெரியல ஸ்டார் வர சொல்லு. So now you can appreciate here. This is the trocar, disposable trocar. This is OptiView trocar I entered. So I am just clearing all the tissues here. You can use a monopolar hook, but this is a little bit faster than that. Write down, Mantra. So I am dissecting below the level of the. Sorry, not above the level of the entry of the trocar, so that my mesh will go above. So this trocar entry also will be covered with the mesh. Light narrow that I down பண்ணு. Okay. So laterally, all the neurovascular bundle to be preserved. So I am going to make trocar here. The gas open பண்ணி உள்ள பாருங்க. So this is the 5 millimeter trocar. இது எடுத்துட்டு holding board. இல்லைடா மாட்டாதுடா, அப்படியே வைடா, நான் வந்துக்கிறேன்டா. ஓகே, கொடு. So this is the platform we are using for long time. Loose பண்ணி விடு, ரொம்ப டைட்டா. So that no, it is Zoom will make a lot of frame drop. Video will be wavery. For just presentation, that is enough, not for a live surgery. So that's why we are using this for long time. And thanks to my AV team and Venkat sir to make all those things. Come. So this is the post-rectus seat, left side, rectus muscle, and இது கொஞ்சம் இப்படி பிடிச்சிக்கு sister. So I'm just dissecting the attachment between the rectus muscle and the post-rectus seat, so that I can able to see the medial attachment of the post-rectus seat, left post-rectus seat to the linea alba. And here we have to be careful. We should not injure the linea alba. Linea alba is the midline structure. Once you injure it, then again, no, immediately subcutaneous tissue will come, and then you are weakening the midline. Can you see here?
Yes, sir.
Yeah, still I am not able to see the linea. Come. Okay. இங்க வா. இங்க பக்கத்துல வை. வேண்டாம் விடு பேசாம. Okay. Usually when I press it and then I lift the muscle, I can able to see the linea. So I'm just trying that. So that might be the linea. So now this much only I can able to dissect. From the attachment about 5 to 7 mm down, I'm making the incision at the post-rectus sheath, left post-rectus sheath, for midline cross. So now you can see I'm introducing my left hand. I push down the falciform. This is the falciform. Can you see the linea, sir?
Yes, sir. Yes, sir.
Yeah, this is the linea alba. Yeah. I'm just pushing down the falciform ligament. Patient had a divarication around 9 centimeter according to the CT scan. So I have to the left. Cross the divarication, then only the post-rectus on the left side will be, I can able to see. Usually the color we can able to see, sir. Can you see, sir, color?
Yes, sir. Yes, sir.
Difference between this color and this color. So that is a muscle. Rectus muscle will joining there. Not much linea. Close up. Some patients it will be seen very clearly, sir. Here I have to see some line of demarcation is able to seen clearly. So anyway, I open up little down. Just I make a nick, I'll see whether I'm entering the muscle or subcutaneous tissue. Not seen. You can see the muscle is not coming. So that means still we have to go down because of the divarication. It is here, sir. I open up here, but down is the muscle. Yeah, பக்கத்துல போனாவே இங்க மசில் தெரியுது பாப்பா.
Sir, any pre-operative planning where to
Only
open
for
the posterior
patient,
rotation?
for opening the posterior teeth, sir.
Yes, sir. Yes.
So that we are not planning, sir. Just laparoscopic view only we are deciding. We are not planning that. Only thing, divarication will we have to see. If a divarication is there, your port will be, initial port will be little lateral, and then according to the divarication level, you have to cross the midline. If it is a 9 centimeter means till about 9 centimeter length, we have to cross it. A small
It's
bleeding in the falciform area.
It's difficult to find the line of
Yeah,
demarcation.
some patients are not all patients. Some patient will be difficult. That's why today also I find difficult. So what I did, I made a small nick. Immediately I could see the fat, then that is a subcutaneous fat. So I changed I changed the site. I went down. Down, Monica. Light down. See, this is the first level I entered. I made a nick. This I will suture it. Now you can see the muscle. This is the muscle.
Okay.
So this can be done, sir. Laparoscopically it can be done. But open this one preoperative wise, even if they mark it, no CT wise, it's sometimes difficult. Fumes. So now I cross the midline. I enter the retrorectus plane on the other side. There is no without pneumoperitoneum. So even if a pneumoperitoneum is happened, that is also it is not interfere my technique. I can able to proceed because my left hand is there. I can press down the tissue. I can coagulate. I can dissect the space. Divarication is not there, then it is very easy to ரொம்ப கிட்ட போகாதடா.
Yes, sir.
Clean பண்ணடா, lens clean. Don't go very close. Clean. And another thing, midline scar is better than this transverse scar for ETED. Transverse scar means most of post-rectus will be they sutured, so will be difficult. Post-rectus seed. Midline means only the linea will be sutured. இன்னும் கொஞ்சம் கிட்ட போயிட்டா. ஓகே, இப்போ வெளியே வந்துரு. Close up. So this is the TA muscle, sir, transverse abdominis muscle on the right side. So when the learning time, what I did, initial of some of my, I think I have done only one case or two case. I thought retrorectus plane I dissected with the initially the same way on left side. I use the OptiV trocar I dissected on the right side. I thought the midline cross will be easier if you dissect the space on the right side. But again you have to cross it, no? So not much useful. So nowadays I'm doing only entering into the left side first, then I cross the midline. Go close. Okay. Is it clear, sir?
Yes, sir.
Yeah. So this is the divided. இது கொஞ்சம் இப்படி வச்சுக்க. PRS. This is the PRS. Left PRS. That is the line of division. Linea alba. You can see linea alba. And then this is the right PRS line of division. And then right rectus muscle. This is the right retrorectus plane. So now I cross the midline. I am going to make this trocar. I am planning a trocar here. So I dissect some more and then I will put the trocar. Come out. See, now I open the, I enter into the abdomen cavity. Falciform is over here. At any cost, linea should not get injured, sir. You can see, no, I am just even with the gas is inside, I can able to dissect. Gas, enter. Okay, go in. Closer. Okay, hold like this. Head up and head down. Knife put. போதும் அப்படியே நான் மறுபடியும் என்ன சொல்கிறேன் அந்த பக்கம் சொல்கிறேன். ஏண்டா கேஸ் போயிடுச்சு போயிட்டுருக்கு. இதெல்லாம் மாற்றாத, எதுக்கு மாற்ற கொடு டொக்கா இருக்கு. ஸோ இன்னும் கொஞ்சம் லேட்டரலாக போட்டிருக்கேன். இங்கே போட்டிருக்க மாட்டேன். சார் அங்கேருந்து பார்த்ததில்ல. So I made this another trocar. Good. Go. Film study sister, அங்க போய் பேசிட்டு. So here additions is there. Okay. So now what I do is, so far I am standing on the left side of the patient. I have done the surgery. Now I am moving to the other side. Towel போடாத. Now I am moving on the head end, so that the patient usually the head end should be free. Anesthesia monitor we push to the right side of the patient, and then right leg is stretched, left leg is tucked. Sorry, right arm is abducted, left arm is tucked, so that I have space to move on the left side. So as much as lateral you dissect, and then try to identify the neurovascular bundle. Don't injure the neurovascular bundle. Close up. This area laterally, if you do it little bit slow, then your field will be clean, because vessel is coming on the lateral side only. கிட்ட போடா, ஏன்டா இவ்வளோ தூரத்தில் இருக்க. So this small vessel you can coagulate so that the nerve will go laterally. Can you see this neurovascular bundle here?
Yes, sir.
Yes.
Yeah. Okay. அந்த 2A இது ஸ்கோபி பண்ணியாச்சா கேளுங்க. கான் டோல் தட் டு என்டர் இன்டு த லிஸ்ட் 2A லிஸ்ட்டில் ஆட் பண்ணால் தான் பண்ணுவேன் நான் ஸ்கோபி. ஓகே. Come here. This is all bowel. Scissor kudu. Here it look like sac da. That is a defect. Inge halut. Once I very near to the bowel, I use only the scissor. I don't use energy device. And here the bowel is down. This momentum is covering the bowel, and that is the content. Hernial content is the momentum. So I use hook. Get off. அழுத்து. Sac also I remove. No, all the case I remove the sac. Some if bowel is densely adherent, then I remove the sac first. The sac down along with the bowel, I just mobilize. If it is only the momentum, I take out the momentum down, and then finally I take the sac.
Suppose the skin is very thin, how will you manage, sir?
Yeah, that is the thing you have to be very careful. Most of the time, skin will not be affected here because you are giving traction and then you are cutting this thing. If it is very close to the skin, cut with the scissor. Don't use cautery. Bowel is there. So all cyst is pressing outside, so that is helping for me. Scissor kuduthal. Near the bowel you should not use. Go. இங்க defect இருக்கா? It looks like a bowel only. This one momentum. So the left hand traction is very important. Even in omental adhesions release or bowel adhesions release, right hand is only the coagulation or cutting with the scissor, but the left hand is giving no traction. It should be very nice traction. So minimal energy is enough to take down the content. So like a Swiss cheese kind of defect, multiple defect. This is also one small defect here. See, momentum is coming up. You can see the defect, small defect. So any open surgery, laparotomy, we could see this kind of Swiss cheese defect. The entire scar will be, the minimal defect. That cannot be, even the CT is not showing that defect. The Swiss cheese defect. Yeah. Scissor. போடாது வேறு சிசர் வாங்க சரியில்லை ஹேண்டிலே சரியில்லை That is the bowel. சிஸ்டர் வாங்க சிஸ்டர் என்ன சிஸ்டர் இதை கொடுக்குற கேவலமாக அழுத்தாத you can see the scissor, the tip, it is not a very sharp tip. Scissor is sharp, but tip you can see it is a blunt tip, so that you can dissect and then cut. So if the tip is so much sharp, then it will injure the structure. So you have to select the scissor. This is the Stores company scissor. So any other scissor also you can select like that. Here it should be, tip should not be sharp. Or otherwise pointed tip should not be advisable. Okay, so here the view is good, and the adisolisis compared with open, you can see the gas is going between the peritoneum and bowel, and then I could able to see the space. So that is the advantage of laparoscopic adisolisis. And you can see I am giving minimal traction, I am not giving much traction, so the bowel should not get injured. And the traction is the one is giving a space between the peritoneum and the bowel. So here it is a little bit adherent, so I am going a little above. So can you see this peritoneum is cut?
Yes, sir.
So I leave the small peritoneum here. Okay. Okay. Clean. So multiple surgery, the adisolisis is the main thing, and particularly open herniaplasty, onlay repair done, patient had a recurrence means the mesh will adherent to the bowel. So that is a very difficult thing. So we have to do very carefully to release the bowel adhesions. ஏதோ ஒரு பொசிஷனில் நில்றா ஆட்டிகிட்டே இருந்தேன் என்னடா அர்த்தம் அப்படியே க்ளோஸ் அப் மறுபடி கேமரா க்ளீன் ஆகலப்பா க்ளீன் பண்ணு கரெக்டாக சென்ட்ரல்லையே க்ளீன் ஆகலாம் அடிஷனலைஸ் அப்போ யூ ஷுட் நாட் ஒரு பொசிஷனில் யூ ஹேவ் டு ஸ்டார்டிங் ஓகே Okay. Close up. Focus. இன்னும் கூட focus இல்லாத மாதிரி. Anything is there, nothing is there. Huh? Diagram போடு, hook கொடு. Hook எப்பவுமே diagram connect பண்ணி வை. பவலில் பட்டுச்சா தெரியலையே. இல்லை. So multiple loop adherence. So always scissor is the best one. Clean பண்ணுறா. So here we have to release the inter-loop adhesions also. Just abdominal wall adhesions if you release, some patients know they have a post-op bowel clean பண்ணுறோம். ஒரு காஸ் வச்சு இதை துடைக்கணும். இதெல்லாம் உனக்கு சொல்லி கொடுத்துருவோம். ஆர்ட்ரி ஃபோர்ஸ் ரைட். ஆர்ட்ரி கூட சின்ன ஆர்ட்ரி. நேஸ்ட்டை லேட் பண்ணிட்டு இருக்க. ரெண்டாம் உள்ள போ. So before releasing the adhesions, I am trying to release the bowel adhesions also. இங்கே வா சிஸ்டர், இங்கே வா. கம் ஹூக் கொடு. This side is clear, no? இன்னொருத்தர் வாஷ் பண்ணிட்டு வர சொல்லு. இந்த பக்கம் வாங்க ஒருத்தர். ரைட்டாக பிடிக்கும். So this is the previous suture line. அந்த இன்ஸ்ட்ருமெண்ட் இதில் வருதா காட்டு? வருது. வா, ரெடியூசர் பவுல் ஹோல்டிங் போட்டுக்க. அந்த பக்கம் அப்ளை எப்படி சொல்கிறேன். இன்னொருத்தர் வா வந்துட்டு. So I am releasing the interloop adhesions first before going for a regular adhesions. One of you was not. All sisters are waste. Put. So in the additions எல்லாமே you have to take it. பிடிச்சு. So most of the patients, they have a pain after meal or distension. That's because of these additions. The patient angle, they thought because of the hernia having pain, but the additions, making the pain. So we have to release it. திருப்பி போடு. கையில் அடிக்காது. இதை விட்டுடலாம். மொமெண்டமில் ஒட்டிகிட்டு இருக்கு. இது இப்படி. So if you do slowly, we can release even the very dense adhesions also. And since that bowel is adherent up, so I'm using the traction. I'm doing interloop adhesions now. So if everything is fall down, then I require some extra port to hold the bowel. Nothing. இல்லை ரிசெக்ஷன் அனஸ்தமோஸ் பண்ணியிருக்குல்ல. அதை விட்டுடலாம். அப்படி வச்சுக்க. Sir, anything, any doubt in adisolysis or your experience when you are doing additions, any enterotomy and then பிடிச்சிக்க.
Is it necessary to release all the additions, sir?
Yeah, so this is the one, sir, because everybody thinks that if there is no obstruction, so is no need to release. But it is better, sir, better to release it. Once you do laparoscopically, re-adhesions formation will not be there. And I'm not taking very dense, loop-like thing. So anything is there, interloop, I'm taking it. And my practice is I used to release all the adhesions, sir. But because of the injury fear, enterotomy fear, people are not doing. We are not doing it, but this will definitely help the patient's angle. They will eat normally. They will not produce any distension or pain. Okay. And these additions, sir, this is the post-ectus sheath. Post-ectus sheath I am going to close. So these additions on the post-ectus sheath to be released. That is must. Yes, even in momentum or bowel, we have to release it. முன்னாடி தொங்கிட்டு இருப்போம்.
So suppose if the bowel is closely adherent to the posterior rectus sheath, how will you release?
Same way, sir. It is most of the time grade 1 addition is the common. Grade 1 additions means there is a 3 grade in additions. Grade 1 to 3. Grade 1 is the one. It is once you give a traction, you will get a cleavage plane. So that is a grade 1. So most of the time you will get a grade 1 additions. If there is a grade 1 is not there, then there is a flimsy additions, grade 1. Grade 2 is if you give a traction, you will get a plane. That is a grade 2. Grade 3 is very dense. That time you have to leave some patch of the post-ectus sheath along with the bowel, and then you can close the post-ectus sheath at the end. That is a grade 3 additions. So that is very rare. And most of the time abdomen tissue, anter-abdominal wall, post-abdominal wall, we can able to get only grade 1 or 2. Once a mesh is there, then you will expect grade 3 adhesions. So mesh, and another thing, a neovascularization will be there. Adhesions will be so dense. So what I do, I just put extra port, even in the right side or left side, I can see the bowel adhesions on all the side, not only one side, no, because now I'm seeing from above down, not only one side, all the side I see the adhesions, and then I leave the part of the mesh along with the bowel. And so all this small bleeder, no, we'll take care at the end. கூட இப்போ கோயில் பண்ணிக்கலாம் பைப்போலர் கொடுத்து. Because I'm going to keep the mesh above the level of postectal sheath. So these adhesions should be there. And if you plan for TAR also, no, this should be released. Okay. Gas piece கூட உள்ள கொண்டு போறது. I'm taking a gas piece inside. Clean. And since the divarication and then defect is also 5 centimeter, so I have to see whether this patient is required TAR or not. If a post-rectus is able to approximate, then is no need. Otherwise, I have to do one side TAR. சிசரா கொடுத்துருக்க கர்டுன்னு நினச்சேன். சரி சொல்லிட்டு கொடு. போய் துடைக்கணும்ல, நான் கர்டுன்னு நினச்சி துடைச்சிட்டு இருக்கேன். இங்கோ. So additions will be like this, sir. Most of the time it will be grade 2 additions.
Okay, sir.
Only thing we have a little bit patience to release it. பிடிச்சிக்க.
What is the chance of developing adhesion again, sir?
Laparoscopically is very, very less, sir. Very less. They tell it's not exact data, but they are telling very minimal adhesions postoperatively. But I couldn't see. In our cases, we didn't go for re-adhesions, re-adhesiolysis in our cases. Gas piece cut. Utra de erra. Suction group. So that is the advantage, sir. Multiple surgery. So some patients, if you ask history carefully, they don't eat normally. After multiple surgery, they reduce their diet, most of the time liquid diet, and then minimal solid, because of they might have some pain. So they thought it is a pain is because of hernia. So after surgery also the pain is there, they will not be happy. So that's why if you do this adhesiolysis carefully, then the pain will be reduced. Good. Come. And my practice is I release the entire adhesion, sir. Because most of the case what I'm doing is now multiple recurrent cases. So I'll expect these type of adhesions. And one case it is 5 times done, laparotomy and then hernia repair. Very dense adhesions, sir. For lady patient, very dense adhesions. It took me 5 hours, 5.5 hours for adhesiolysis. And then another almost 2 hours for hernia repair. So 7 hours to 7.5 hours it took, but 5.5 hours is adhesiolysis. மாற்றி மாற்றி பிடிக்கணும்டா எனக்கு தெரியிற மாதிரி அப்படியே வச்சேன்னு எப்போ தெரியும். And even open also, we are doing additions. But open bowel is coming out and lot of contact with the pad, G pad, the mop. So these are all the things making additions, contact to the open air. So all those things. But laparoscopically, it is not much contact to any other atmosphere. So it is easier. So it looks a little bit boring, but I consider it is important, sir.
Will you keep a intraperitoneal drain, sir? Intra-abdominal drain?
No, sir. No intraperitoneal drain. At the end, if even nowadays, even extraperitoneal drain also, I stopped doing it. Sometimes after TAR, I used to keep it, not all the time. And if it is any blood-stained area is there, or extensive TAR done, both top and bottom, then I go for this one. Then I go for a drain in extraperitoneal space, not on intraperitoneal space.
Sir, for example, if enterotomy happened in this phase, you repaired it with the suture material, do you proceed with the same plan of mesh or any change of plan will be there, sir?
No, sir, no change. Even IPOM we can do with after enterotomy. Only thing, it should not be too much contamination, entire division of bowel like. Enterotomy means you can don't do further adhesiolisis because the adhesions will help you, and close it with the PDS nicely. Then you continue proceeding, and then you can keep mesh, no problem. But only thing, you have to keep the patient for hospital for 5 days with IV antibiotic. That is, the study is there. So they are recommending IV antibiotic for a week, and you can continue. Even multiple enterotomy also, you can continue, you can keep mesh. And those days, enterotomy means no, we don't keep mesh. We abandon the procedure. But nowadays, the concept has changed. And only thing, 5 days IV antibiotic, they are recommending it. And maybe orally you can delay for some time, like that. நீ பிடிக்கிறது எனக்கு ஒன்றும் ஹெல்ப்பாகவே இல்லை. As much as possible release. Okay. Abdominal wall cut. The bowel required. நீ வராத. So here again you can see it looks like very dense adhesions, but you can see just I am taking, pulling it out. So immediately I could get some space. So I am utilizing the space. See, like this. So this is, here I can say around even grade 1 and 2 only. Close up. Usually in conferences, we don't put these type of cases because we want to show multiple case in a shorter time. So you will not get to see this chance to see this type of adhesiolisis. But anyway, this today you can able to. Left hand traction is no very important one. That is another bowel loop. These loops and all, it is in the abdomen, pelvis. Scar is here. So this is the defect and scar, but adhesions on the lower side is more. Gas fish suction. உன்னோட இன்ஸ்ட்ருமெண்ட் குறுக்க வந்து இடிக்குதுடா, வெளியே எடுத்துரு, யூஸ் பண்ணாத ஏன் உள்ள வச்சு. சக். So clean that area with the gauze piece, then you can do. The mess is not exposed here. Come. Never be. Put it. Camera rotate. So I am leaving some part of the peritoneum or a sheath in case of difficult adherent area. Okay, gas piece. Close up. I am cutting the sheath. Suction. So once I release this bowel, then I can go for a mobilization and then I can keep suck. We had another cases that is a very simple paraumbilical hernia. So I don't want to. I want to show some. No E-tap. Nowadays we are doing E-tap for a difficult case only. Near the costal margin or suprapubic space, lateral wall hernias or multiple recurrent hernias. We are doing E-tap.
So for which cases you choose IPOM, sir?
So IPOM for regular, sir. Even particularly young patient, small hernia, you can do IPOM. But if you ask me, we can do any case E-tap, even the small 3 centimeter W1 M3 hernia, paraumbilical hernia also we can do E-tap. But sometimes if you are a young patient, thin patient, so what happen, that patients may require TAR. Because of the post-rectus sheath we are reviving, we cannot approximate. So that's why Young patients, I'm avoiding E-tip, particularly young ladies, thin ladies. Otherwise, you can do, but IPOM is again no important is there. Nowadays, complex abdominal wall hernia, then E-tip is a choice. And learning phase, you can select a thin patient, obese patient with a smaller hernia. So obese patient with a smaller hernia, that is a good for beginners. So once you learn the technique, then you can go for a complex case for E-tip. So initially you select obese patient, particularly little old patients, and then obese general abdominal wall, even a central obesity is also okay. You will have a lot of space. You will get a lot of space in obese patient. Good, good. For learning phase, you can do smaller case, then you go for a difficult. But always E-tip is taking time. Your time IPOM you can finish fast. Even in IPOM, this case you have to do these additionalisis. Extra some interloop additions I released. Suction. But these additions you have to take it out. Even in IPOM. And suppose if it is a 5 centimeter or more than 5 centimeter defect, then again E-tip is indicated. Why? Even in more than 5 centimeter, you can able to approximate the defect by reducing the pressure. But what happen? It will produce some intra-abdominal hypertension. So that's why the clear-cut indication of IPOM is the defect size horizontally 4 centimeter, vertically 10 centimeter. So if it is 4 by 10, you can go for IPOM, horizontal 4, vertical 10. If it is more than that, it requires some kind of component separation. In open, we are doing IPOM. We are doing a anterior component separation. Compared with the anterior component separation, what we are doing here, posterior component, in TAR, that is better. So we are doing a TAR, E-tip for a larger defect. Is it clear, sir?
Yes, sir.
Yeah. So here it looks little bit dense adhesions. Close up. Camera ஏண்டா ஆட்டிட்டு இப்படியே போயிடும் அசையாமல் போயிடும் இப்படி லைட்டு திருப்பிட்டே கிட்ட அப்படியே வச்சு இதை மட்டும் ரிலீஸ் பண்ணிவிட்டு வில் கோ நான் அதர் சைடு ஆங்கிளே சரியில்லை வந்துடுச்சு ஓகே ಸಕ್ಷನ್ನ ನೀ ಟಕ್ಕನ ಗಾಸ ಕಾಣ್ತೀನಲ್ಲ ನಾನೇ எடுத்துட்டா இதெல்லாம் இதுதான். ஓகே. க்ளோஸ் அப். இப்போ அடிச்சு. அடிச்சு. டேய் இப்படி புரா இப்படி பிடிச்சின்னா இடிக்காது. இப்படி இப்படி if you release the interloop adhesions, it will give a good exposure so that the further adhesions will be easier. Otherwise, everything is like a clump, no? So you cannot proceed for further adhesiolisis. So now this area, because I release, I could able to see this area very clean. எடுத்து close up. Come. Light, yes. See another loop of bowel, very thin bowel. Why this type? How much? Why this very dense adhesions? I don't know. It is not a scar. Good. No mesh, but very dense adhesions. Okay. Good. Close up. இன்னும் கூட க்ளோஸ் அப் போடலாம். Go.
So does your instruments reach there till pelvis, sir? Is there any difficulty?
Yeah, it is not reached, then we can change the port, because I have another port in lower abdomen. For left side, it is there. Right side, I can put another port, sir. If you have a long scissor or long instrument, you can use. Usually, we have a long needle holder. Suppose if I want to fix the mesh to the Cooper's ligament, I use the same instrument because a long instrument from the same port. So otherwise, you can make extra port in the right lumbar area or right iliac fossa. You can do the dissection, sir. We have a long Maryland, long folding, long needle holder, but I don't think long scissor. Scissor same height, length only, sir. Go, do it, okay. External view coming, man. டேய் போயிட்டாங்களா, யாரும் இல்லையா? எக்ஸ்டர்னல் வியூ வந்து இந்த போர்ட்ஸ் காமிக்க வந்துட்டாங்க. போர்ட்ஸ் எல்லாம் காமிங்க எங்கிருந்து ஆப்ரேட் பண்ணுறேன்ட்டு. So I'm operating from above, sir, standing on head end, and then I'm using camera trocar that sublay, this one subcostal camera, that is the OptiView trocar on both side end, both side of the trocar will be working. I'm working from that side port.
Sir,
all midline port.
Patient is
but
in
it is
neutral
reaching, sir.
Head down position.
What is the question?
In this step, well, the head down position will help you in adasolysis further, sir.
Yeah, definitely, sir. Already head down is there. Sir, இன்னும் கொஞ்சம் head down பண்ணுங்க, sir. போதும், டேபிள் ஹைட் பண்ணு.
So ideal table height to do these steps.
Table height usually, where 29 will be the lowest height. All the companies are making 29 inch from the floor. That is the lowest. For a regular patient, that is okay. For obese patient, that will be little more height. So in that case, in that case, you can ask the company. Nowadays, they are making it with. They are making it with 25 inch lower height. So you can make it 25 inch height. So 25 inch height from the floor. And I used to very particular on table height in the beginning, in the beginning of my time. Nowadays, I adjust my port. You can see here it is very close ports, close to the trocar, so that I am not keeping my hand abducted. So you can see in the external view, all the time my shoulder is very much normal position. So I don't have any shoulder pain, even long time operating. So that's why I'm not concentrating on table height nowadays. I'm concentrating on ports, so that even the table is little bit height, I can able to do without difficulties. So this everything is because depends on your port position. So place the port close to the camera port, so that angle scope you can able to see. And you have to educate the camera surgeon. Camera surgeon they find a little bit difficult if it is a close-up port, but you will be very much comfortable. Your shoulder will not get strained. So almost all additions released. That is very important, sir. Ergonomics. Otherwise, you spend a lot of time to learn the surgery. Once you after learning it, you will have some pain. You cannot do. You cannot practice. So that's why ergonomics is considered very important nowadays.
So if the port is closer to the camera port, will there be little crowding and the camera person will be
Yes,
finding
yes,
the
yes. See,
between?
my left hand, இதை க்ளீன் பண்ணிக்க. டேய் கேமரா இதை காமிக்க முடியுமா? கேமரா இதில் எடுத்து காமி, லேப்பில் எடுத்து காமி. So I'm placing the trocar, you can see. Can you see here, sir?
Yes, sir. Yes, sir.
This is the camera. This is my left hand camera. This is right hand. I have a good amount of space. Left hand is very close. Otherwise, I can use this one for left hand. But so far, I'm using this is for left hand. This is for retraction of bowel. You don't feel any crowning effect. Clean பண்ணி உள்ள போ. இப்படியெல்லாம் பண்ண க்ளீன் ஆகாது. என்ன சொல்லியிருக்கேன்? அது எப்பவுமே அங்கே இருக்கணும் காஸ் பீஸ். So you can see the clearly, sir. Camera is very close parallel to the left hand. Right hand is coming perpendicular. So when I working, I will get around 60-degree space. And since it is a angular, that is 30-degree camera, we can rotate and then we can see the additions all around. So that around 4 centimeter maximum distance, sir, from between the working port and the camera is enough. So we are planning nowadays. We are using like this, so that we are not having any pain or anything, and the suturing also is, we feel very comfortable. If we go laterally, so what happen? Your hand is abducted, shoulder and hand is abducted, so you will get pain. You cannot do surgery for long time. So most of my patient ETAP will take around 3 hours to 4 hours because of the complex case only. I'm doing ETAP nowadays, and but I don't feel any pain post-operatively. This after a long time also, I don't feel any pain, sir. That may be because of the port. So now entire additionalize is done. Suction light up. So now I am going for mobilization of the PRS.
Excellent additionalization, sir.
Yeah, additionalization is over, sir. Even any interloop additions, if it is dense, I release, but I'm not feeling any dense addition. Some of the interloop additions already released. That's why if you release all the bowel, then you start interloop additions, then the holding will not be there. So you have 2-3 instruments to hold the bowel. That's why if you see the interloop additions during additionalisis, release it immediately, then you continue the additionalisis. Okay, sir. Any doubt or anytime you feel any enterotomy or anything? I couldn't see during surgery. Doubt irundha zero cell tire mari? No doubt, sir. Because entire team opinion is very important than the surgeon opinion. Okay. So the gauze is there. Good edutharla ipo. Ready, sir? Put. Avanta kudu. So the gas has come out. Suction. Okay, come here. Good. So now you can see the defect, and then posterior also, this is very densely adherent. I feel some difficulty. I'm expecting some difficulties there. Light narrow. Yo, calculate. Usually with this pressure, I'm pressing down, no? This pressure itself, it will open. So today, because of the horizontal incision scar, So most of the post-rectus, no, they will suture it. So it is not going. Muscle and post-rectus together. Scar dana. So this is the scar area, yeah. Almost around. Scar area is little bit difficult, but if you injure the post-rectus sheath, or no problem, but you have to suture it. But as much as possible, we try to preserve it. Otherwise, no, we required sometimes bilateral tar. It will take a lot of time.
So anyway, this case will need tar anyway.
Yeah, this case definitely, sir, because the divarication is also there. Close to the linea alba, I'll go, but I should not injure the. I should not injure the linea alba. So here there is no muscle. There is no post-rectus sheath. Only the muscle is exposed here. Go. Definitely, sir. It is so much gap. Go. That's why the transverse scar is making us trouble. Usually what I do, the edge of the lower edge of the defect, within 2 centimeter the linea will end. So I used to, no, within a centimeter or 2, I used to connect both sides at the lower edge of the defect. So here also I am trying that. So I'm going to connect this here.
So connection happens below arcuate line, sir?
Usually at the end, edge of the defect, or within 2 centimeter from the lower edge of the defect. If it is umbilical, mean within 2 centimeter. If it is a lower umbilicus, below the umbilicus, at the lower end of the defect, you can connect both the sides. Linea ends, sir, usually that place. So it is wide. So that is a problem of transverse scar transverse scar. The entire length you can see it's more than 10 centimeter. No, more than 10 centimeter distance is there. Definitely it required tar. Bipolar. Any small bleeding from the muscle, you coagulate and then proceed. Because the muscle is the one, when I started contraction post-operatively, it will bleed. Here and all miss. previous mess might be here. Here, regular distance. Almost no post-ector seat. Mari. ரொம்ப மோசமாக இருக்கு. ஐயோ டயத்தெர்மி கொண்டு I should have selected the different case for a demonstration so that I can finish fast. கொஞ்சம் I am taking time. So there is a lateral wall is reached, but there is no post-ector seat at all. Because of the suturing of the previous surgery. Come. The surgeon doing a TEP, no, they might be interested to seeing these type of cases. The beginner surgeon, they feel a little boring, no, they feel bored. So almost TA muscle is there. So much lateral, no, it is. இல்லைடா சாக் இல்லைடா அது அந்த இது சூச்சரிங்க அது லாங்கிடியூடினலாக சூச்சர் பண்ணி இப்போ மசில் எல்லாம் ஒட்டி சூச்சர் பண்ணிட்டாங்க எல்லாம் எலாங் வித் மசில் போஸ்டெக்டர் சிட் டுகெதர் தே டேக் அ ஸ்டிச்சு ஸோ நோ அதர் ஆப்ஷன் see so much gap still So one of the very toughest case for TEP, ETEP. So I thought after additions, I can able to get a space nicely, but I'm not able to get it. Left side is better than right side. If it is a clean case, no, I could show the anatomy well. Here the post-ector sheath ends. Ligature கொடுக்குறியா இல்லை வேண்டாம் அது கொடுத்து இல்லை அது ரொம்ப ஹார்டாக இருக்குது லிகாசூருக்கே கஷ்டம் திக்கு இதை லிகாசூர் கட் பண்ணாது ஸோ ஐம் ட்ரைங் டு ஜாயின் ஹியர் So usually it will be like this, sir. It will separate automatically. That is the edge of the postectus sheath, line of Douglas,
Okay.
arcuate line. Bipolar கொடுத்துரு. Bone might be here, sir, but it is far away from the defect, so I need not to go till the bone. So now this is the wide area here. It is more than 10 centimeter here. So அங்க போ லெட்ல போ. So I'm going to release the postectus sheath. Tip clean பண்ணி கொடு sister. So that I can do tar and then close the postectus sheath. And the right side is very less the breadth of postectus sheath is there. Suction ಕೊಡು. ಕೊಡು. Hook. அங்கே எங்கடா கேஸ் இதில் தான் போகுது, டொக்கார் வெளியே இருக்குது. கொடு. க்ளோஸ் பண்ணிட்டு இருக்கு. Okay, come here. So I'm coming to the left side now. So I'm going to release the postectus sheath. First I release on the inguinal side, then I come on above, then I do tar. After tar again இன்னொரு gas piece கொடு. So here and all there is no sheath at all here, this place. See, it is no sheath. Even it required bilateral tar, it seems. I'll see. Success. Go. Take it off. Go. So the space of bowgrass to be dissected, curved. Once you dissect the space of bowgrass, then you will give some loose peritoneum there. Then you can able to proceed faster. That will facilitate no, some kind of approximation. Hook கொடுங்க கனெக்ட் பண்ணி okay, this will I'll come little later. Come here, suction group. So now I'm going to do tar. I'll show you how to enter into the tar plane. So that is the one many surgeons they find difficult. Once you enter in the right plane, then you can divide the muscle easily. Now you can see now very much gap between the this side to that side. It has to approximate. It's almost around 20 centimeter gap is there. Okay. So for getting a tar plane, ஒரு மணி ஆயிடுச்சா? So you have to see the neurovascular bundle. So you can see
Yes,
the
sir.
neurovascular bundle is here.
Yes, sir.
So that area is little bit weak area, and you can able to. So see that is a muscle, TA muscle.
Yes, sir.
See the nerve is going up. So you can select that plane to open up the tar area. So here the post-ector sheath continuation is there. I am not dividing the post-ector sheath. And immediately within short distance, no, another you will expect another neurovascular bundle. Close. So this is the inferior lamina of the internal oblique muscle. What I am dividing is the inferior lamina of the internal oblique. So it will expose the tar plane. That is a transverse abdominis muscle, raw muscle you are able to see now. that is also pushed upwards. Huh? Okay. Close it. So when you come up, the muscle is more medially placed. When you go down, the more aponeurosis, less muscle. Eh? You can see the insertion of muscle. I am dividing the muscle now, just around 5 to 7 mm from the insertion. So that area muscle is little bit thin built and not thick. If you are close to the internal insertion level, some tendinous portion will be there. So I'm going little away, around 5 to 7 mm down. What you are seeing, this is the post layer of transversalis fascia. So what the procedure I am doing now, it is called TAR. That is a transverse abdominis muscle release. Clean. You can see I am not using any energy device. Even monopolar is good enough. Hook, monopolar hook. I have a not ligature is there. Ligature is best compared with the monopolar.
Suppose if there is a rent in the posterior.
Yeah, there is a rent in the post layer of transversalis. We have to close it.
Close it
And
immediately or
you
not?
don't, yeah, not immediately, sir. You have to dissect on either side or select the different place, then start a new dissection and then come to that rented area, then suture it. Because we need some tissue mobilized, then only it will able to suture. Otherwise, it will cut through, sir. Because of the thin structure, you have to mobilize, then come for closer. So here only the TAR alone is not enough. We have to do the posterior component of full dissection of the transversalis fascia from the TA muscle to be done.
You always use a hook or some other energy sources.
So I always use hook, sir. I don't use any energy device, ligature or something. Only hook I am using it for all my cases.
Okay.
When I do previously, almost 10-15 years back, with a harmonic also, many people tell, no, we don't have harmonic, you'd use monopolar or bipolar for any other surgery. But nowadays, any hospital have an energy device. So, which is comfortable for you, you can use, sir. Ligature means I have to change the port. Port site I have to change it, this one, because the angle is not good here, ligature. Tip clean one. So here I am going for a pre-peritoneal plane because it is here you can see the TA muscle is going much laterally. This is the internal oblique muscle is coming. So I'm going to do pre-peritoneal plane because here almost 3 centimeter above the level of arcuate line, all the layers together, all the aponeurosis, because this is the neurovascular bundle, all the aponeurosis become together, it will form a single layer. So if you try to go in this plane, TAR plane, then we will injure the nerve. Can you see this now neurovascular bundle? So we will injure the neurovascular bundle. This is the neurovascular bundle. So here I am entering into the pre-peritoneal plane. Basically here I am dividing the post-rectus sheath. Closer. So another bundle is coming up. So this is another neurovascular bundle. Curved group. So here that is the peritoneum. So we have to be very careful. If you get plane in one place, then I can dissect. Uh, 3 centimeter above the level of arcuate line, we have to convert like this. Gas piece. Suction. Suck. Suck. இல்லை ஹூக் இந்த கேஸ் பார்த்தோன்னே செல்வராஜ் சார் நெக்ஸ்ட் கேஸ் கூப்பிட மாட்டார்னு நினைக்கிறேன். நெக்ஸ்ட் மீட்டிங்.
So no sir, everyone are enjoying the
everybody is enjoying sir.
ஓகே ஓகே சார், தேங்க்யூ சார்.
Okay, okay. We'll have a
எனக்கு
working.
பிஜிஸ் எல்லாம் சொன்னீங்களா, அதனால கொஞ்சம் சின்ன கேஸாக இருந்தால் நல்லதுன்னு பார்த்தேங்க.
Okay,
பட் இந்த கேஸ் தான் கிடைச்சிது. சரி,
Very wonderful case.
Actually, you got the all collections in one case. All the steps, everything.
எதுங்க சார் சரியாக கேட்கலைங்க சார்.
Herniaல வந்து என்னெல்லாம் all the steps you have bring out here.
அதான் ஆல்மோஸ்ட் எல்லா ஸ்டெப்பும் இதில் வந்துருச்சுங்க.
ஆமாம். It's a great thing, sir.
ஓகே, கம்.
Actually, we Delta ASA, we have to thank you very much, sir, because we have got a long relationship. Last midday second, Professor Painiveli has come and he made it a grand function, sir. And
Yes,
also
sir.
you are all supporting every time, sir. We on behalf of ASA Delta, we thank you very much, sir. We want to continue your service, sir, medical service. towards the
Thank you.
postgraduates and also for the young surgeons, sir.
Yes, sir. We are very happy, sir. Even not even live surgery, sir. Even lectures, videos, anything can be possible because
Okay,
this
sir. Okay,
platform
sir.
is a very nice one.
Okay, okay.
It will give a very clear view, sir.
Yeah, yeah,
It is
yeah.
like operating in the there itself. That vision will be like that. No, so much
Yeah.
clear vision. It will.
Transmission is very good, sir, and
Yes,
clarity
sir.
is very good, sir.
Yes, sir.
Actually, many surgeons were present in Tanjore Medical College also on that day, sir. But
Okay,
here
sir.
there is no interruption here, sir. Actually, we have got a very good.
அங்க ஆமாங்க சார் அங்க வந்து I didn't know that they are doing with the Zoom.
Yeah, yeah, yeah. But here it is really good, sir. Really very good.
Thank you, sir. Thank you so much.
Okay, thank you. We have to thank you,
We
sir.
are we are also very happy, sir. And anytime
Okay,
you tell me, we'll connect like this.
okay,
And
okay,
we have team basis or any multiple surgeries or because we are operating daily, sir. All the
okay,
our
okay,
faculties, each unit they have a very good experience. So
okay,
all the surgeon can participate here in gym.
okay, okay,
So it is it will be nice, sir. You can see the different
okay,
surgeons operating on the same day.
okay,
We
okay,
are
okay,
happy, sir, because it is our regular list, regular work. So we are
okay,
transmitting, so that's why we
okay.
are not suction.
Sir,
Yes, sir.
Partha, Dr. Sundararajan.
Sir, good morning, sir.
Morning. How are you? How are
Good
you?
morning, sir. Fine, sir. Thank you,
I
sir.
saw
Thank you for the
silently.
opportunity.
Yeah, silently we
Solid.
have been watching what the wonderful
Oh,
confidence you have given, the wonderful confidence regarding adhesion. Super.
Thank you, sir. Thank
With
you, sir. Thank you, sir.
meticulous dissection, how to use the energy instrument, how to use non-energy instruments. எல்லாம் பிரமாதமா பண்ணிட்டீங்க. Wonderful.
Oh, super. Thank you,
Hall
sir.
is hall is spellbound. Nobody has got up.
Oh,
எல்லாம்
thank you, sir. Thank you, sir.
keenly watching. Wonderful.
Thank you,
All the
sir.
best.
Thank you so much, sir. Thank you, sir. Thank you, sir. சார் நேற்று சொன்னாருங்க சார் நான் கேஸ் ஆரம்பத்தில் உங்களை இன்வைட் பேசாமல் விட்டேங்க சார் சாரிங்க சார்
From Praveens work, I've been sitting and watching totally.
Oh, thank you, sir. Thank you, sir.
Coimbatore will be running away, not here.
Yes, sir.
Enjoying. Bye.
That is always okay, sir. Thank you, sir. Thank you so much, sir. So this is another important step, sir. So we have to mobilize this post layer of transversalis fascia from the TA muscle. So just you can see I'm just pushing the muscle like this. Close. So this is the plane, sir.
Yes, sir.
Who could
Up to which level you are going to go posterior and laterally, sir?
Up to what level, what length we want, sir? So usually we can go up to psoas muscle laterally, posteriorly. We go in this plane up to the psoas muscle. Then only I can able to reach it, sir. Otherwise, I have to do another side tar. That is also no problem. But even to tar also sometimes it will not reach. You can see the extraperitoneal pad of fat is retroperitoneal fat is coming.
Yes.
Jemmy is always welcome, sir, because Palnivel sir made this pathway of this teaching and then video transmission and other thing. live surgeries, how to go. So we are practicing it, sir. Suck, suck, suck. In open technique, during open crowd, open we just push that fascia, this one muscle. We hold the muscle like this with the instrument, and here we are doing very slowly. And on and off some blood vessel will be there. So it is not going means this is the blood vessel. I have to coagulate. Hook. ஆல்மோஸ்ட் ரீட்டோ பெரிட்டோனை தாண்டி போயிட்டு இருக்காங்க இப்போ.
எஸ் சார்.
அந்த ஒரு இடம் மட்டும் ரீட்டோ பெரிட்டோனை தாண்டிடுச்சு. ஹியர் ஐ ஹவ் டு ரிலீஸ் இட். அந்த சுவாமிஜி இது ரிப்போர்ட் என்னாச்சு? எண்டோஸ்கோபி ஸ்கேன் கவுடு கொடுத்து here just below the post layer is a peritoneum, sir. This is the peritoneum. This is the post layer of transversalis.
Yes,
if
sir.
you open the post layer, if injured the post layer, then peritoneum will open, or we will go to the peritoneal level. This is a young patient, young bulky obese patient. If it is a old patient, then this step will be easier, sir.
You should not injure the linear semillunaris, sir.
This one, sir, post layer of transversalis, yeah. Linear semillunaris crossed, sir.
Yes.
So now it was very, very less. So now I can able to get up to this level, but this is also, I think it's not enough. I have to do other side tar, sir. Go. Who could assist? In open, we use our finger to dissect these areas, finger and hand, so that we will reach the psoas muscle easily. So this is called TAR with PCS, sir, post-component separation. So it was like this. It was like this. So only very small amount of post-lecture sheath available. I release, and then you can see how much length, almost 10 centimeter, almost 10 or more than 10 centimeter I dissected, sir.
Superiorly up to subcostal.
Yes, sir, we can go up to subcostal, and when you are going superiorly, we have to be very careful. The diaphragm fiber will come and join to the TA muscle, subcostal level, and so I'm going to be very careful in that place. If you see the muscle is thicker, then I will stop, sir.
Yes, sir.
If it is a M2 hernia, epigastric hernia, then we have to do like this, or I do bilateral TAR and then I close it. Because diaphragm muscle is injured means each inspiration and expiration the patient will have pain. So if you are going close to the costal margin, when you are doing a TAR, thick muscle is coming, then that means the diaphragm is fibers also joining the TA muscle.
Okay,
We have to
okay,
stop,
sir.
sir. So I'm going to finish here, and then I have to check whether adequate or not. If it is not adequate, then I have to release the muscle on the other side also. It will take another half an hour time extra, but we can able to approximate nicely, sir. Good, good. The correct angle of traction is important, sir. Otherwise, this thin structure will get teared immediately. If you are doing it with the correct angle, retraction of tissue with the correct angle, then this will not tear, sir. That is one to be learned. Bipolar கூட இழுக்குது பாரு, என்னால் பண்ண முடியாது. ஒரு தடவை நல்லா இருக்கு, ஒரு தடவை இழுக்குது. Can you see this layer, sir? Down பண்றேன். This layer
Yes. Yes, sir.
that has to be preserved, yeah. இல்லை கவுடு இதில் So that is the maximum one can done in the towel area. Okay. You go, வெளியே வா. Come this side. So now I am going to try to approximate both. If a tension is there, then I do release of PRS on the other side. So that is the gauze piece. Go. So it is a little bit tension only. It is not, I can't approximate. You can see after so much release, I'm excellent. So I'm going to release this one. For a proper TAR, bilateral TAR, I have to put extra port, and then I required extra monitor on the left side of the patient. இது diathermy code. So that I can approximate, sir. Otherwise, if I do only the release of PRS and then do only the pre-peritoneal dissection, then is no need for extra monitor. I think I required extra monitor system. இந்த மானிட்டரையே எடுத்து வைங்க, அதே முடிஞ்ச எடுத்து வைங்க. டொக்கா 2 எக்ஸ்ட்ரா எடுத்து வச்சுக்க. க்ளீன் பண்ணி கொடு கிஃப்ட், அதுக்குள்ளே ஏன் வாங்கி வைக்கணும். சரி, ஹூ கொடுங்க. So you can see the neurovascular bundle there.
Yes, sir.
So I just releasing the post layer of transversalis fascia. So now I release the post layer of transversalis because from arcuate line 2 centimeter above the arcuate line, all it joined together. So I can come up to 3 centimeter, then I can enter the tar plane. Hook. கவுடு டைத்தரம் போடாமல் வெறும் கவுடு மட்டும் ரெண்டு மாற்றி மாற்றி கப்ப ரெடியாக இருக்கு. So that is a neurovascular bundle. So I have to preserve that one. டைத்தரம் போடு. ஓகே, உட்கார எடுத்துக்க கொஞ்சம். ஆ ஆ ஆ ஆ ஆ ஆ ஆ ஆ இங்கே இங்கே ஆமாம். இல்லை, இது கொடுக்க சொல்லிடு. ஸ்டூல் டெஸ்ட் வேணால் முடிஞ்ச கொடுத்துட்டு போக சொல்லு. பண்ணிக்கலாம். So I have to avoid the nerves. So I am just looking for a place to put port for a bilateral tar. I put another 5 mm இருந்தால் ஒரு 5 mm வச்சுருக்கேன். 10 போட்டுக்கலாம். சரி விடு, இதே டக்கு டக்குன்னு மாற்றிட்டு இருக்கணும். So I am making another port.
Which level, sir?
This is above the level. I'll show you, sir. Lateral side, in between the nerve fiber, I made it. Clean. இந்த பக்கம். So this is the camera port. This is the right hand, left right hand working port so far, left hand working port. Now this is the right side, sir.
Okay, sir.
I thought it is a linear assembler, so after release it is be here. So I'm going to make one more port here. So
Yes, sir.
I'm going one more. So these three will be used for right side tar, sir, left side tar.
Okay.
Because this case, you can see the scar is so long scar, it is coming up to this level. So I don't have any post-ector sheath, and they have a drain also here. So up to this level, I'm not getting the post-ector sheath. So that is the reason I come for bilateral tar. Now I'm coming this side. இப்படி போக முடியுமா அப்படி வரணுமா இதை எடுத்து வைக்கணுங்கிற நாலேஜ் இல்லாமல் இருக்கு. So I have not shown a bilateral tar live so far because very take long time. Most of the case I manage with unilateral.
We are lucky, sir. We are lucky to see bilateral tar, sir. Here.
With adisolysis. With adisolysis. Adisolysis is the same thing.
நீங்க ஓட் பண்ணிட்டீங்களா?
ஆமாம், நேற்றே பண்ணல சார். அவங்க மார்னிங் சார் வாங்கிட்டாங்க சார்.
இங்கே பண்ணிடலாம்ல சார்?
நம்பர் மட்டும் சொல்லிட்டீங்கன்னா
பண்ணிடுறாங்க
இல்லை உங்கள் ஃபோன் கொடுத்துட்டீங்கன்னா ஒன்றுக்கும் அந்தந்த இதில் தான் பண்ண முடியும். ஃபோன் வாங்கிட்டு நீங்கள் இது பண்ணிடுவோம், லிங்க் வாங்கிட்டு
கொஞ்ச நேரம் சொன்னோம்னா முடிச்சுக்கணும்.
இல்லை நீங்கள்
இது
போடணும்.
ஃபோன் மட்டும் ஓடிபி வரும்.
மெயில் ஐடி எல்லாம் கொடுக்கணும் சார்.
ஒரு முடிஞ்சாலும் வரணும்.
சார் ஈவினிங் வச்சுதான் நிறைய இன்னொரு 20 பேர்
கொஞ்சம் கூட்டமாக சார்.
கம்பெனியில் கரெக்டாக 25 பேர் சொல்லியிருக்காங்க. 25 பேரும் சொல்லியிருக்காங்க. அதுக்கப்புறம் நான் சொல்லியிருப்பாங்க 50 பேர் சொல்லி 25 பேர் இருப்பாங்க.
உங்களோட உஷாராக போய்
அது கூட ரிலீஸ் பண்ணி சிஸ்டர் மட்டும் டொக்கர் புடி ஃபர்ஸ்ட் கோ மேன் கோ இன் சார் உள்ள போடா உள்ள போடா
அதனால எங்கெங்கே
ஏண்டா டொக்கர் உள்ள தள்ளுவாங்க.
லிவர்
ஈஸியாக தான் வராது. ட்ரைனிங்கு ஸ்டாமினா டீம்
போட்டால் ஒரு நாளைக்கு
தஞ்சாவூரில் ஒன்று பண்ணாங்கன்னா சார் பண்ணலாம். அதுவும் அதே மாதிரி 3-4 மணி நேரம் ஆச்சு. டிரான்ஸ்மிஷன் முக்கியமான ஸ்டெப் பார்க்கணும்.
இது
சூப்பர் நல்லா இவங்க பார்க்கும்போது இவ்வளோ டிரான்ஸ்மிஷன் சூப்பராக
நெட்டில் ஓடிடி வந்துச்சு சார் ஜூமில் போட்டார் சார்
கேபிள் கேபிள்
கேபிள் போட்டு கேபிள் போட்டு சார் செட்டிங் ஒரு ஜூமில் வச்சு பக்கத்தில் வந்து
முக்கியமான ஸ்டெப் போயிடுச்சு. அதுக்கப்புறம் அந்த வீடியோ கேட்டால் ரெக்கார்டட் வீடியோ ஒரு இது இருக்குங்கிறாங்க. இன்னொன்று என்ன வைக்க சொன்னாங்களா போஸ்ட் ஆஃபீஸ் போஸ்ட்
Very partial, if we divide, it will be easier.
பார்த்தோன்னா ஒரு ஐடியா வரும்னு பார்த்தோன்னா கிடைக்க முடியாது.
மசில் கட் பண்ணி ட்ரான்ஸ்ஃபர் ப்ராசஸ் பாசிபிள்.
Okay. Focus பண்ணு.
ரெண்டு கடையில் வந்துருச்சா இன்டர்னல் போய் கடையில் வந்துருச்சு. ஆமாம் அந்த பிளேன் நல்லா அழகாக வந்துருச்சா. அது ரெண்டுத்துக்கும் நல்லா தான் இது ஹீரோ பஸ்ஸில் அந்த பிளேனில் தான் இந்த ஹீரோ பஸ்ஸில் கொண்டு வரும். அதை போகக்கூடாது.
நல்லா வளர்க்கணும் அப்படியே போய் முடிச்சு
அது என்னாச்சு டார்ச்சர் ஆகிடும். மென்டல் டார்ச்சர் அந்த மாதிரி டாக்டர் கொண்டு ஆரம்பிச்சிட்டு அந்த ஸ்பேஸ் ஆஃப் எக்ஸைஸு ஸ்பேஸ் ஆஃப் போக்ராஸ் இருக்குல்ல அதில் க்ளோஸ் பண்ணி மசில் இருக்கும். பக்கத்தில் ஃப்ளாட் இருக்கும் அந்த ஃபேஷியா உறிஞ்சவங்க நல்லா உறிஞ்சு வந்து ஃபுல் நர்வம் எக்ஸ்போஸ் ஆகிடுச்சு.
Here. So far I released the PRS, but here I'm going to divide the PRS because all together, all the layers here.
சொல்ற மாதிரி நாலாயிரம் பர்சன்ட் அதுலேருந்து மசில் பக்கம் நிறைய பெரிட்டோனை தாண்டி பெரிட்டோனை
Pre-peritoneal plate, correct. So that is the plane I developed here already. So the same plane it's going to join. So that neurovascular bundle will not get injured because here it is very close. If you try to go in a tar plane here, you will injure the neurovascular bundle. அந்த 1 or 2 bundle sacrifice ஆயிரும். அது ஆகக்கூடாதுன்னு சொல்லி we are going like this.
அதுதான் அந்த மாதிரி போகுது. கீழே மசில் இருக்கு, மசில் மேலே இருக்கும். இப்போ நீங்கள் போகும்போது பார்த்து தெரியாதனால தான் நீங்கள் அந்த இதில் பார்த்தீங்கன்னா 2 பக்கமும் மசில் இருக்கு. உஷாராக இருந்துடும். அந்த எக்ஸ்பீரியன்ஸ் தான் தான் தெரியும். இதில் பாருங்க கீழே வந்து மசில் அங்கே இருக்கு. இது மேலே சார் இது கீழே
ஓகே.
இன்னும் ரிலீஸ் பண்ணதில்ல நல்லா போகும்.
Clean பண்ணி கொடு. If I do tar, that is enough. No need for PCS.
Sir, plane
permanent post போக வேண்டியது. Just tar is enough.
மசில் எடுத்தா தான் ஆக்சுவல் டார்.
இவ்வளோ சொல்லிட்டு கொண்டு வந்துட்டாரு. நான் உண்மையிலே முடியாதுன்னு தானே நிறைய இழுத்து கொண்டு வந்துட்டாரு. ஊருக்கே இவ்வளோ நேரம் ஆகும். இன்னும் 10 நேரம் ஆகும். டைம் மூன்றரை மணி நேரம் ஆயிடுச்சு. இதுக்கப்புறம் மேலே க்ளோஸ் பண்ணுவேன். க்ளோஸ் பண்ணணும். பேஷன்ஸ் பொறுமையாக பண்ணுங்க சார். நிறைய இருக்காரு. எவ்வளோ டைம் வந்து ஃபாலோ பண்ணிட்டீங்க. உண்மையாக அவர் ஸ்லோவாக தான் போகிறார். அனஸ்தீசியா காம்ப்ளிகேஷன் நிறைய ஃபேக்டர் அதுக்கு மேலே சைஸ் வச்சுருப்பாங்க. ஜென்மம் எல்லாமே வச்சுருப்பாங்க. நம்ம என்ன பண்ணுவோம், ஒரு இது பிளான் பண்ணிட்டு போவோம். அது பத்தாது, அடுத்தது என்ன பண்ணணும்னு தெரியாது. இல்லை மாதம் இல்லைன்னு நினைக்கிறேன். அது மசில் லேட்டரலாக போச்சு. லேட்டரலாக போச்சு.
So almost it is finishing, sir, here. Okay.
லீனியர் சிமிலர் ரிசல்ட்டில் அது ஒரு முக்கியமான ஃபேக்டர், முக்கியமான இதுன்னு சொல்கிறாங்க. அதை டேமேஜ் பண்ணக்கூடாது. அதை டேமேஜ் பண்ணால் டிசாஸ்டர். நம்ம டிசாஸ்டர் எல்லாமே எட்டப்படலாம். ஒரு முக்கியமான ஸ்டெப்.
Focus பண்ணிட்டு
அவ்வளோதான். ஏன்னா திறந்துட்டு மூட முடியும்னா உடஞ்சும் அதோட செத்துக்குவான். அதுதான் அவன் தலையெழுத்து போனான்னு சொல்லிட்டு இவனை விட ஏதாவது என்ன வச்சு ஏதாவது பண்ணுவாங்க. இந்த ஃபேஷியல் டென்ஷன்
தேங்க்யூ சார்.
ரொம்ப ப்ராஜெக்ட் கொஞ்சம் வேஸ்ட் ஆயிடுச்சுங்க. ஹரிசாண்டல்ஸ் காரணனால. ஆக்சுவலி ஹரிசாண்டல்ஸ் காரணம் வெயிட் எஃபெக்ட் பண்ணக்கூடாது.
மிக்க நன்றி. ஒரு கனத்த இதயத்தோடு இந்த கும்பகோணத்துக்கு நான் முடிப்பேன். கனத்த என்ன காரணம் அவங்களோட அன்போடு எக்ஸ்போர்ட் பண்ணுவாங்க. தேங்க்யூ வெரி மச் ஃபார் வண்டர்ஃபுல். தேங்க்யூ வெரி மச்.
சில டிஷ்யூ வந்து செப்பரேட் ஆக மாட்டேங்குது. ஃபியூச்சர் மெட்டீரியலாக வாங்கி வச்சுக்கோங்க. மேலே ஸ்டார்டாக ஃபிக்ஸ் போட்டு. So now it is loose. I think it will come. Good. We'll suture and then if it is required, we'll do it again. We release some more after.
Thank you, sir.
Palikista. கூட ஸ்டார்ட் ஃபிக்ஸ் கொடு. ஸ்டார்ட் ஃபிக்ஸ் கொடு. சரி இது கொடு செக்ஷன் கொடு. So I'm going to close the gas எவ்வளோ ஒன்று இருக்கா ரெண்டு இருக்கா? ஒன்று தானே? செக்ஷன். So I'm going to close the anterectus sheath for now. Mostly it will I can able to suture the postrectus sheath. So, எடுத்துடலாம். So I'm going to release the sac.
Okay, sir.
And then I started a closer of the anterectus sheath. Sorry, linea alba. And some cases, if it is a M3 W1 or W2, M3 W2, thick sac, long-standing hernia, you can utilize the sac for closer of the PRS. But I don't follow that. I don't like it. Basically, it's not that much thick. And once you release all around the blood supply also, I don't know how much it is there. So I'm not practicing that. That is once you learn TAR, any difficult situation you can able to manage with the TAR. So that's why
Sir,
learning
have you
TAR
faced
is very
any?
important. Yes, sir.
Have you faced any situation, sir, in where after even doing bilateral TAR, the closure has been a little bit difficult, sir?
Yeah, that is not in lab, sir. For open surgery, some cases I'll take the case without this one Botox and triple P initial phase. Initial period. So that time even bilateral TAR done open, I could not approximate the PRS. So in that case, I just put the this one composite mesh to cover the defect in the TRS.
Okay, sir.
You understand, sir?
Yes, sir. Yes, sir.
Yeah, mostly 15-15 is enough, round mesh, so that that will be taken care the PRS closer. கையெடு சிஸ்டர் அழுத்தக்கூடாது சாக்கு எடுக்கிறப்ப. That was happened two times, sir. 2 times. Then after that, we learn Botox and triple P, so that we are not facing that problem. Suture. So I'm taking a barbed suture. This is a Stratafix from Ethicon company, and we can have a PPT from Covidian. Both can be used. This one done. One Stratafix, 45 centimeter, 37 mm needle. I'm taking it. So I'm going to start 40 mm needle. I'm taking.
So anti-rectus, you are using non-absorbable sutures, right, sir?
Yeah, it is a delayed absorbable, sir. We can use non-absorbable is better, but nowadays we are using this one also, because many studies shows that it is a delayed absorbable, also good for facial closure. PPT is non-absorbable. What we believe it is stronger than the PPT.
Okay, sir.
So sometimes very wide defect, PPT it will cut through. It is dividing. It will cut when you are pulling it. And this is another thing is a symmetrical type of. You can see it is like a fish bone. Close up, photo.
Yes, sir. The barb is rexim.
Yeah, it is a fish bone type. Yeah, so it will be holding strength is more, and it is a little bit stronger than the PPT. What we are using it, we are finding it. So most of case we use PPT, and some cases we use this one. So I start little down, lower down. Two things is made difficult today, sir. One thing is divarication. That is common. Another thing is the transfer scar, sir. Transfer scar means almost occupying 2/3 of abdomen, so that it is a lot of post-rectus sheath or waste. So.
But still, this looks very quick for us, sir, with the adhesiolysis also, sir.
Yeah, additions also unbelievable. So it is so much additions. I expected on the scar side, but in the pelvic area also a lot of additions. So from I'm needless and from here to here I'll close. So I'm thinking how to go. So I'm going this side first, and then I'm coming from. Pressure கொஞ்சம் reduce பண்ணிட்டு 10 வை. Usually when I tighten the knot, tighten the suture, at that time I used to keep 8 pressure. So 8 will almost like a normal abdomen without any stretch. So if we keep 12 mm and then if we try to close, tighten the suture, it will be difficult, sir. So I'm doing like a plication kind of suture. You can observe here.
Yes, sir.
So I'm not doing with my 2 hand. So I'm doing it with my single hand closer. So now I touch the needle with the abdomen wall. I turn the needle direction. I'm taking on the other side. So this time I came to left to right. Now with the one, see each stitch, around 1 centimeter gap, and then each row 1 centimeter gap. I'm going to the right side to left side now.
So you are taking bites like crisscross patterns.
It is it is a zigzag, sir.
Zigzag. Okay, sir. Okay, sir.
Zigzag. Okay.
But usual closure will not be like this, no, sir. But for this
Usually
case,
will
you
not be.
altered.
If a divarication is not there, you can do like a left to right always, sir.
Okay, 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 sir. Okay, sir. You are chosen to take zigzag because of.
Because of if I take this edge and this edge, so what happen? Center will be like a no bulge.
Okay, sir.
So
Okay, sir.
approximation will not be adequate. So I choose like this. So now if I close the, if I tighten the thread, it will become a vertical column like, entire
Okay,
thing
sir.
will come and closer. ரொம்ப தூரமாக வச்சுருக்கான்டா கேமரா. ஜூம் பண்ணிட்டானா? ஏன்டா ஜூம் பண்ணிட்டேன்? கேமரா கொஞ்சம் ஜூம் எடுத்து விட்றா, ரொம்ப ஜூம் பண்ணிட்டாரா டே, உனேதான்டா. ஜூம் பண்ணிட்டானா ஃபோக்கஸ், ஜூமை கம்மி பண்ணுறான். அப்பர் மாற்று. போதும். ஓகே, இப்போ ஃபோக்கஸ் பண்ண, அப்போ தான் ஃபோக்கஸ் ஆகும். எங்கே டிஸ்டன்ஸ் ரொம்ப இருக்கா? ஓகேவா? கம்மியாக தான் இருக்குது. இன்னும் கொஞ்சம் கீழே வரணும். கையெடு. It should not include the muscle, only the linea I take.
Okay, sir.
Okay, இப்போ ப்ரெஷர் 8 வை. சீக்கிரம் போ, டக்குன்னு வை. அங்கேயே நில்லு, மாற்றி கேட்டு. சிக்ஸ் வைங்க. எடுத்துடு கேஸ். It is very difficult. It is not getting approximate. கொஞ்சம் டைட் பண்ணுறப்ப அப்படி பண்ணு. த்ரெட்டை பிடிச்சிட்டு இருக்கேன். கேஸ் எடுத்துடு, அதை க்ளோஸ் பண்ணிட்டு. எயிட் வை. டுவெல் வைங்க. இங்கே ட்ரக்கார் காமிடா. டவுன் பண்ணு லைட். இப்போ வந்து ஹியர். ஓகே. So now I keep 8 and then I tighten the thread. So again I come back to 12 now. So So almost the supraumbilical region I'm working. Monitor the கொண்டு வா sister. அப்பளவே சொன்னாரு. அப்படியா? Primary closer oh, because of obstruction primary closer. இது சக்ஷன் கூட ப்ரெஷர் ரெடியூஸ் பண்ண ரெடி ஆயிக்கங்க. எங்கடா இருந்தாரு? சரி வெயிட் பண்ணி பார்க்கலாம். ட்ரை பண்ணி கேஸ் திறந்துடு.
ஆன்டி ரெட் பேசிக் கீழே இருந்து ஸ்டார்ட் பண்ணிட்டாங்க.
சொல்லு வை சிஸ்டர் போ மேல போ. Go that side. போப்பா அங்க வந்துச்சு போ. போடா.
So now you are changing position for the
Yes sir, because I'm closing on the upper side, that is above the level of umbilicus. So I'm from mid head end, I'm moving on to lateral side.
Okay sir.
But I'm watching the same monitor. If you have extra monitor on your right side of the
இது என்ன கம்பெனி சார் தான் சொன்னாங்க. மசில் எடுத்துக்கிட்டு இருந்தேன் சேர்த்து. கம்பெனி தான் சொன்னாரு. மசில் எடுத்த பெயின் நமக்கு இந்த ரெக்டர் ஷீட்.
பரவாயில்ல, பிஜி பண்ண சொல்லியிருக்கீங்களா? டீச்சர் அப்போ தான் நல்லா இருக்கும் சார்.
பண்ணுங்க பையன் பார்த்து பழக்கம் இல்லை சார்.
ரொம்ப இன்ட்ரெஸ்ட்.
எயிட் வைக்க ரெடி ஆயிக்க. ஓகே, 8 வச்சுக்க. ஓப்பன் பண்ணி 8 வச்சிரு.
ஃபார் எக்ஸாம்பிள் அம்பிளிகல் என்ன சொல்லுங்க.
So the angle is no problem when you are coming up.
சரசரம் இந்த இதுல போகலாம். இதுதான் கம்மியாக இருக்காது மெட்டீரியல்ஸ். அது கொஞ்சம் லேர்னிங், ஹை லேர்னிங்.
Up to what level I open the expose the linea, I close, sir. Same way PRS also, up to what level I expose, I used to close.
Sir, it looks easy for us, sir, but is it easy actually there, sir, closing the area?
It is, yes, sir, it is very difficult only. So since we are using this barbed suture, even left side to right side, right side to left side, depends on the situation, you can change it. But it can be done, sir. It will be just if you practice 2-3 cases, then it will be done.
But the dini alba has to be completely closed, right, sir?
Yes, sir. Yes, sir. Definitely, it has to be closed, sir. Even if you leave it a small portion in the upper side, is no problem. But in that case, post rectus to be closed.
Okay, sir.
Because sometimes what happens, they leave this area, area they don't close it. So they don't close. So what they do, no, they think that it is this one falciform ligament is there. It will take care of the miss, but it will be misconduct will not be there to the bowel because of the falciform. But that is a weak area. So our initial phase in 2015 or 16, some of our junior colleagues started learning that technique. So they couldn't close it, entire post rectus sheath. So we have a recurrence in the upper side. So
like
that is the reason nowadays supraumbilical, epigastric.
Yes, sir.
Yes, sir. Recurrence. So that's why we are nowadays we are closing all the thing. So now I finish it and then I started taking a suture on the PRS now.
Yes, sir. Yes, sir. The same sutures you are coming down.
Yeah, same. So because suture is there, I'm coming down PRS closer with the same suture.
Any change in patient tables, sir, like head up portion, anything?
I'm not doing it, sir. I don't think that table position will help.
Okay.
If you find difficult, if you place the patient in abducted leg, then you can go down and then stand between the leg, you can suture. That is the only option, sir.
Okay, sir.
But today I keep the patient supine. All the I don't put the upper abducted. Most of the time I'll manage with this suture, sir. In
So
this
while
position.
suturing from below upwards, sir, by standing in head position,
Yeah,
in
pressure எவ்வளோ
female
இருக்கு?
patient,
Increase பண்ணிக்க. Yes, sir. Yes, sir. What is the question?
yes, sir. Sir, while closing from below upwards, sir,
Okay.
by standing in head and position, in
Okay.
female patient with huge breast, have you faced any difficulty
Yeah, yeah,
in
yeah, yeah.
standing?
Yeah, that time I used to keep more head down, sir.
Okay, sir.
More head down, and then if I feel very much difficult, then I come to the lateral side, and then I
Okay,
started closing from the lateral side, sir.
okay, sir.
The patient got a large breast, no? Sometimes that problem we are facing it. I try to keep the head and down, even though it is not possible. Then come to the lateral side and then
Lateral
abduction.
side. Sir, for example, if the posterior in rectus sheath there is an interlying peritoneum in between without any peritoneal
Yeah,
defect,
you can. Yeah, you
prefer
can use
closing.
it, sir. Yeah, people are using it, but my practice is post rectus closer, sir. But
Even there
even if
is
a
no defect.
peritoneum is there, if you use that is acceptable one.
Okay, sir. But still you
Acceptable,
close
sir.
for
That
all
is.
your cases, sir, right, sir?
Almost, sir, all cases, 98% or 99% I can tell. Like this, you can see this. There is no
Yes, sir.
peritoneum or no false form. Only post rectus is there. Like this, I close almost all my patients. என்ன பிடிக்க முடியல கவுடு கூட
You plan to keep drain for this patient, sir, in
Yes, sir.
period
Definitely, I'll keep drain because of the bilateral tar. I'll expect a lot of seroma, and usually seroma will be there for 2 days. Sorry, 3 days maximum. Some patients 4 days or 5 days, and till about 100 up to 100 ml, I used to keep the patient in ward. Once it's 100 ml is there, then I discharge, sir. I
suction
don't
drain
wait
what
to
size, sir?
suction, sir. Regular suction, 16 ready vac,
Single,
Romovac
single,
drain.
single or single drain or two
Single
drain?
drain, single drain.
Single drain.
This case also I'm planning to keep only single drain, 16 French.
Policy of removal, sir.
Drain serial fluid less than 100 ml or less than 100 ml.
Okay, sir.
So I don't want to waste the thread. So you can see, no, it's very comfortable approximation, sir.
Yes, sir.
Most of the time in upper abdomen we will find difficult. Since because of the bilateral tar, it's very comfortable. I have to see in the scar area in the middle of the abdomen because a lot of PRS is wasted there. I have to see. So that's all. Over. I will go back once and then I will take it. Okay. 30 centimeter one. கொஞ்சம் டைட் ஆயிடுச்சு ஒர்க் பண்ணுறதில்ல
சரி ஓகே சார் ஓகே சார் ஓகே தேங்க்யூ சார்
கொடு 10. So now I'm taking a 10 PDS, sir. 10 PDS, long needle. Come here for a PRS closer. Clean. 2 பேர் இருக்கு தின்னா வைக்கணும் ரொம்ப திக்கா இருக்கு வெளியே எடுத்து சக்ஷன் கொடு.
Thank you, sir. Thank you. All the best.
Thank you,
All
sir.
the best.
Thank you.
No, no. Thank you.
காசு வெளியே வந்துருச்சுல்ல சார்? ஓ, இங்கே தான் இருக்கா? ஓகே. சக் இந்த எடுத்துருக்கேன். காஸ்ட்லி இது இருக்கு. அவ்வளோ இல்லைங்க. குடு சிஸ்டர். ஏன் சிஸ்டர் வெயிட் பண்ண வைக்கிற? வேடிக்கை பார்த்து திரும்பி பேசுறதுலாம் ஒரு இப்படி நீட்டில் விட்டு அதில் கவுடு போட்டு பிடிக்கிறது. நோ கேப்பில் நோ கேப். வெயிட் பண்ணு வெயிட் பண்ணு வெயிட் பண்ணு வெயிட் பண்ணு. இப்போ வந்து கொடு. Leave it, leave it. Whether coming this side, I don't know. வச்சே பார்க்கல. வந்துருக்கான். ஐயோ. ஓகே. இது ப்ரெஷர் ஓப்பன் பண்ணி விடு. அந்த பிஆர்எஸ் க்ளோசர் டைம் கீப் ப்ரெஷர் 8. Two things, sir. I'm a little bit different from others. For a PRS closer, I'm taking a stitch very closer stitches. You can see it's only 5 mm or less than 5 mm. And then second thing is, leave it. Second thing is, I'm taking a thicker suture material. Usually people use 2-0 or 3-0. I'm using a 1-0 suture material. So large suture and then closer bite, so that PRS, it will hold well. PRS rupture will not be there. So that is one of the very worst complication, PRS rupture. That is because of the tight closer and then thin suture material with the tight closer. Patient stretch means it will leave, stitch will come out, but here you can see it is very relaxed way it is there, and there is no tightness because of the bilateral tower. Leave it. $45 வாங்கியிருக்கலாமா? Good. பிகாஸ் அது திக்காக இருக்கா ஒவ்வொரு சுவிட்சருக்கும் நம்ம எடுக்கணும் இல்லைன்னா வரமாட்டேங்குது. இது பத்தாதுன்னு நினைக்கிறேன். நினச்சேன் 45 வாங்க சொல்லலாமான்னு, கொஞ்சம் பண்ணங்காட்டி தான், அதனால தான் நானும் இதை எடுத்தேன். இல்லைன்னா இன்னொன்று வாங்கிக்கிறேன். கொடு. கொடு. வேறு கம்பெனியில் ஏதாவது 20 சென்டிமீட்டர் இருந்தால் 15 வந்து அதுதான் 10ல் 15 இருக்குல்ல, அது பிபிடி இல்லை, அதுதான் 20 தான் இருக்குது. சரி இதே வாங்கிக்கலாம், அதெல்லாம் நல்லா இருக்கு. பிரிக்க வேண்டாம், வாங்கி வைக்க சொல்லு. இல்லை போதுன்னு நினைக்கிறேன், போதும். ஃபீடிங் டியூப் 6 சைஸ் கொடு, வாங்கி 30 சென்டிமீட்டர் கட் பண்ணிட்டு. என்னடா ஈச் பைட்டு டைப் பண்ணோம்னா உனக்கு அப்படியே வச்சுக்கிறேன். எவ்வளோ இப்போ இன்க்ளூட் ஆக வாய்ப்பு இல்லை, நான் இழுத்து தானே பண்ணுறேன். கொஞ்சம் அப்படி அது ரெண்டுமே ஒட்டிக்கும் போல இருக்குது, பக்கம் பக்கம். எவ்வளோ தூரத்தில் இருந்துச்சு? 20 சென்டிமீட்டருக்கு பக்கம் இருக்கு, 20 சென்டிமீட்டர்.
20 சென்டிமீட்டர் சார், அது கொண்டு வந்துட்டாரு. பெரிய விஷயம். நீங்கள் பண்ணுறீங்களா? இது அதான் சார் ஸ்டெர்லைசேஷன் வந்து சார், வீடியோ ஸ்டெர்லைசேஷன்
பிடிக்காது என்ன டைப்
வந்து நீங்கள் ப்ராப்பர் ஸ்டெர்லைசேஷன்
அப்படி
சராடு இல்லை, வீடியோவுக்கும் அட்வான்ஸ் இல்லை.
ஒன் மோர் அவ்வளோதான்
வரல பெரிய டிசாஸ்டர் மிஷன்.
என்ன வாங்கி என்ன விலை இருக்குது சிஸ்டர்? வாங்கிக்க இதே கட் பண்ணிக்கிறேன். குடிமே ஒன்று எடுத்துட்டு திருப்புடா எடுத்து. So I'm taking another switcher because if I take 45 centimeter it would have been ideal, and now it is a little bit difficult because I have to handle 30 centimeter length of suture for suturing about 5-6 centimeter PRS closer. 45 கொடுத்துருந்தீங்கன்னா கரெக்டாக இருக்கும். அதை விட்டுறா, அதை விட்டுரு இதை படிச்சு. வெளியே வந்துருச்சு. இங்கே கட்டுற இங்கே போடுற லெஃப்ட் ஹேண்ட் வெளியே வந்துருச்சுடா. வெளியே வந்துச்சுன்னு சொன்னால் நீ புரிஞ்சுக்க மாட்டேன். இங்கே வா பிடிச்சி. இல்லை விட்டுரு அங்கே போகணும் நம்ம. சரி பிடி இன்னொரு பைட் எடுத்துடலாம். ஸோ வி ஆர் கம்மிங் க்ளோஸ் டு த எபிகாஸ்டியம் இல்லை. ஸோ இஃப் யூ கோ லேட்டர்லி தட் இஸ் பெட்டர். இங்கே கொஞ்சம் லூஸ் விட்டு, ரொம்ப இழுக்காத. டுவர்ட்ஸ் பெல்விஸ் இழுக்க சொல்கிறான்டா. இதெல்லாம் ரொம்ப லூஸாக இருக்கிறங்காட்டி இதெல்லாம் ஒட்டிச்சு. See, so much, relax. தூக்காதரா. The bilateral TAR gives around more than 15 centimeter defect approximation. Pura. இது இதனுடைய இதா இல்லை அதனுடைய இதானா? அங்கே போ, லேட்டரில் போ. ப்ரெஷர் கொஞ்சம் இன்க்ரீஸ் பண்ணிக்க. 10 வை, 10 or 12 வை, நோ ப்ராப்ளம். கொஞ்சம் என்னுடைய அதர் ரெண்டு இங்கே வருது. நடுவில் அந்த டிஷ்யூ ஏதோ போய் மாட்டிச்சு. ரெண்டு எடுத்து நடுவில் ஒன்று இருக்கு. இது வருதா, இதை இழுக்கிறோமா? இல்லை ஏதோ நாட் ஆயிடுச்சு, கட் ஆயிடுச்சு. ஏதோ நாட் ஆயிருக்கு சிஸ்டர், கட் ஆயிடுச்சு. கிளீன் கிளீன். அது லாங் சூச்சர் ஹேண்ட்லிங் இஸ் டிஃபிகல்ட். இங்கோ அங்கோ. அவளில் ஒன்று மாட்டி இருக்காதல்ல, மேலால தான் இருக்கு. இப்போ லாங் ஃபியூச்சர் ஷார்ட் ஆயிடுச்சு. 2 பக்கம் 5 சென்டிமீட்டர் வேஸ்ட் ஆயிடுச்சா? சிஸ்டர் கொடு, பக்கம் முடி. அதை விடு விடு, இன்னொன்று கட் பண்ணி ஏன் எடுக்கிற? 2 இருக்குல்ல, என்ன நினைக்கிறோமோ அது பண்ண மாட்டேன். பிடிச்சி வரமாட்டேன். அது கூட பிகாஸ் ஆஃப் த திக் சூச்சர் இஸ் நாட் பெண்டிங், பெண்ட் ஆக மாட்டேங்குது. Okay, now it's another only 2-3 sutures, and any doubt or anything about ETEP? So I'm going to measure the entire dissected area. 12 which sister pressure. Measure it with the feeding tube so that it has a mark inside. So length, correct length I can measure, and then I will keep a mesh according to the length. Then I fix the mesh to the upper border in the falciform area, only 1 stitch. If I keep it till the Cooper's ligament, I'll keep another stitch on Cooper. This case it is not Cooper, it go up to the bone level, but it is no need for lower stitch. And people they are keeping self fixation mesh. Since they are not able to suture the mesh, they cannot use taker also here. So some surgeon they use a self fixation mesh, self gripping mesh otherwise. Some surgeon they use a glue to fix the mesh, but actually if you cover it nicely and then fix it in one place, it won't migrate. See, almost that is the previous suture. That is the previous one. அதான்டா ரெண்டே எடுக்கணும்டா. நான் அதை மிஸ் ஆயிரும், லேட்டரில் போகிறப்ப எடுத்துக்கலான்னு தான் அப்படியே வச்சுருந்தேன். இங்கே ஆ 12 வச்சுக்க ப்ரெஷரு. இது கொடு, ஃபீடிங் டியூப் கொடு, அதில் ஒன்றும் வேண்டாம். 30 சென்டிமீட்டர் கொடு, நீடில் ஹோல்டர். So I'm taking a feeding tube in. Clean. இங்கே தான். So initially those days previously I used this one cotton tape. So nowadays using this one, surgeon used this one, then it looks nice, then we copied, then we are using. See, it is a 30 centimeter length of feeding tube. You can say it is okay, correct. So now I am going to do the sideways measurement. இங்கே வா. Okay. Come. இங்கே கோணை ஆகிற வரைக்கும் எங்கே காட்டு. இப்படி பிடிச்சிக்கிறேன். பைலட்டல் டார் பண்ணியிருக்கோம்லடா, ஆல்மோஸ்ட் இது வரைக்கும் வருது. இது என்ன நம்பர்? 26. 30 by 26 கொடு. 26 வச்சுக்கலாம். அங்கே போறியா? எடுத்துடலாம். 30 வாங்கிக்க. 30 26 கொடு. இந்த வாங்கிக்க. செக்ஷன் பண்ண ஒன்றும் இல்லை. ஒன்றும் இல்லை. ஓகே. So this is the closer. After closer, you can see the anterior linea. It is not visible at all. Here only minimal visible. So previous before closer it is so wide. So now you can see this, and externally also you cannot see any bulge or something. It is flat only. So I am taking a 30 by 26 centimeter mesh. சீக்கிரம் குடிச்சிட்ட. என்ன கட் பண்ணவே ஆரம்பிக்கலையா? சீக்கிரம் பண்ணு. மெஸ்ஸு காமிடாத. எக்ஸ்டர்னல் மாற்றிடு பசுபதி. ஃபுல் ஸ்க்ரீன் போட்டுரு எக்ஸ்டர்னல். இவ்வளோ தான் இருந்திருக்கு பிஆர்எஸ். இங்கே பாரு, இவ்வளோ தான் இருந்திருக்கு. இல்லைடா இல்லை எனிவே டிஃபெக்டை ட்ரான்ஸ்ஃபர்ஸ் பண்ணிவிட்டு தென் லீனியாவை யூ ஹேவ் டு க்ளோஸ் பட் மோஸ்ட் ஆஃப் தம் இட் வில் கம் பிகாஸ் வி ஆர் டிவைடு வி ஆர் போஸ்ட் ரெக்டஸ் ஆல்ரெடி டிவைடடு ஒன்லி ஆன்ட்ரெக்டஸ் ஹோல்டிங் தான் வந்துடும். ஸோ இதில் பாரு எவ்வளோ பெருசு இருந்துச்சு ப்ரீவியஸ். ஸோ என்ன ஸ்டெப் பண்ணுற சீக்கிரம் கொடு, லேட்டரில் கர்வ் பண்ணு டக்குன்னு மேலே கீழே. மேலே கொஞ்சம் மினிமமாக பண்ணு போது பண்ணு அதோட கொடு வேணா நான் கட் பண்ணிக்கிறேன். கொடுங்க மேலே இன்னும் கொஞ்சம் பண்ணிடு. கீழேயே நல்லா கருவு ஆகலை போல தெரியுது. ஆச்சா கொடு வேணா நான் உள்ளே கட் பண்ணிக்கிறேன். கொடு, நீ ரொம்ப ஸ்லோவாக பண்ணுறேன். கொடுங்க இன்னும் சதரமாக தான் இருக்குது சிஸ்டம் மெஸ்ஸு. கீழே கோணிக்கீழே ஆகலை பாரு. நல்லா பண்ணு. சரி கொடு. இட் லுக்ஸ் ரெக்டாங்கிள் தான்டா, ஸ்கொயர் தான்டா. இப்படி டேப்பர் ஆகுது. தள்ளிக்கு பின்னாடி போ. கீழேயா ஃபாலோ பண்ணுறா. அப்படியே வெளியே வரும். இதோ ஒரு கையில் எடுக்காத, உட்கார் வெளியே வந்து. எங்கடா ஒழுகுது? இன்னும் கூட ஒரு சென்டிமீட்டர் எக்ஸ்ட்ரா லேட்டர்லாம். லாங் கொடு மிட் லெவல். So it is lies flatly. Okay. Only this area I can trim little bit. But also I can able to tuck it. Go. கூட ட்ரிம் பண்ணிடலாம் சிஸ்டர். வரல இப்படி இப்படி இதில் எடுக்கிறேங்க. இதே இப்போ லாங் கொடுக்குறேன். அங்கே போ. ப்ரோலின் 10 வாங்கிக்க. ட்ரெயின் ரெடி ஆகிக்க. ட்ரெயின் மாற்ற சின்ன நீட்டில் போட்டு. ட்ரெயின் மாற்றுறப்ப க்ளவ் மாற்றிக்கணும். இந்த பக்கம் வந்து ட்ரெயின் போட்டு. இதெல்லாம் இழு சிஸ்டம் அங்கே பாரு. ஓகே இங்கே ஓகே கொடு. இங்கே மட்டும் ஃபிக்ஸ் பண்ண சுவிட்ச் அழுத்தாதுரா. கொடு கொடு ஒரு சுவிட்சர் தான் கொடு. அதை எடுத்துக்க. அங்கே பாரு அந்த தொக்கா இருப்பார். இப்படி இதை பிடி. Okay, and this is a falciform area, so my stitch will not hold any bubble or momentum. இப்படி இன்னொரு சுவிட்ச் எடுத்துட்டுமா? அங்கேயே ஒன்று இருக்கு. இந்த பக்கம் வந்துருச்சுல. க்ளவ் போட்டு ட்ரெயினுக்கு க்ளவ் போட்டுட்டு இந்த பக்கம் வாடு. இங்கே வா. கேமரா இங்கே வா. நீட்டில் ஹோல்டர் கூட எனக்கு. இங்கே இந்த பல்காக இருந்துச்சுல்ல அங்கே ஒன்று எடுத்து விட்டுலாம். சூச்சர் காட்டு. The prospective sheet closer that area is so bulky, so I thought of taking one stitch superficially. Got it? Not போட்ட எங்கடா இல்லை விட்டுடலாமா? என்ன பவல் மாட்டிடக்கூடாது எடுக்கிறப்ப, அது ஒன்று தான். இங்கே ஒன்றும் இல்லை ஃபேட்டு தானே.
Sir, is it compulsory to fix the mesh, sir?
Actually, not compulsory. My concern is I'm keeping drain. When pulling out the drain, something
Mesh
should not
okay,
happen. No movement of the mesh. Long kudu.
Okay, sir.
இல்லை இதில் kudu. Reducer kudu. Long
For
kudu.
For internal reverse stoppers, you do you fix mesh, sir?
Cooper, sir.
Taper.
Means Cooper. Suppose if I take a Cooper stage, then it is a 2-point fixation, upper one, lower one, so it won't move. Here also just for just holding, sir. But usually it will not happen because other areas are it is come and stuck to the mesh, so it won't allow the mesh to move. Just for safety sake, I am checking. That area is only the extraperoneal pad of fat, and will be there. So that I fix it to that place.
Okay. Sir, excellent, very excellent demonstration, sir. Thank you so much.
அங்கே போயிருக்கோம் சின்னது. Thank you, sir. And I'm going to keep a drain. Keep a drain, and then I'll come out. And I thank my team. பசுபதி எல்லாரும் எக்ஸ்டர்னல் வியூ, இந்த ட்ரெயின் வச்சோன்னா எல்லாத்தையும் எக்ஸ்டர்னல் வியூ ஒன்று காமி. இந்த பக்கம் வா, இந்த பக்கம்.
Very excellent demonstration. And
thank you, sir. Thank you so much.
Wonderful surgery, and we are all very happy here. Thank you very much, sir.
Okay. Enjoy. Thanks for the opportunity, sir. Tell us, push. Only one drain is enough because there is no bleeding, sir. Very clear only. கொஞ்சம் எடுத்து.
So for here also JP drain or suction drain, sir? Your preference?
This is suction, sir. Suction drain.
No more, sir.
Ready wax suction, sir. பாரு. Suction kudu. Some dribbling from roof, 1 or 2 blood drop. So I just coagulate. Inga da suck pannu. Suck. Bipolar கொடுத்துரு. Suck. இதில் ஒன்றும் இருக்கிற மாதிரி இல்லையே. சரி, ஓகே, ஒன்றும் இல்லை. இப்போ இது கூட நீல் ஹோல்டர் கூட கேஸ் க்ளோஸ் பண்ணிக்க. எவ்வளோ டியூப் வெளியே இருக்காட்டு? ஓகே, கம்மியாக தான் இருக்குது. அது இழுக்குது பாரு டியூப். சரி, ஓகே. இப்போ இது கேஸ் க்ளோஸ் பண்ணிக்க. இந்த பக்கம் வாங்க. டொக்கார் நல்லா வெளியே இருக்கா பார்த்துக்க. ஓகே, இங்கே வா. ஓகே, கேஸ் எடுத்துடு. லைட் அப்படியே சைடில் வச்சுக்க. Okay, sir. Thank you.
Sir, thank you very much, sir.
Thank you so much. Thank you so much for the opportunity. And
thanks,
I'd like to thank my team.
Okay.
Lakshmanadas is doing a DNB. Final year is Pranav, again DNB student. And technician Radha, staff nurse Saudiswari, Huh? Abhirami. So, and my AV team, Pasupati and Alagar. So, all, all of you, thank you so much. And thanks for the opportunity, sir. Maybe in near future, we'll get a very good case. Short time, no, we'll show multiple cases.
It's very good.
Excellent.
Thank you so much, sir. Thank you, sir.
Thank you very
Thank you,
much,
sir.
sir. Thank you, sir. Actually,
Thank you, sir. Thank you so much.
sir, we have to thank you. Actually, I don't know how to thank you all and your wonderful team, excellent work. And also, I want to thank our Pioneer sir for all the opportunities through which you are doing wonderful service. Thank you very
Yes,
much,
sir.
sir. Thank you, thank you.
Thank you, sir.
We want
Thank you,
to
sir. Thank you
continue
so
our
much.
your,
Yes, sir. Yes, sir.
your
Any day, sir.
okay,
As you said, even evening time also. If
okay,
you
sir.
tell me before, we'll keep cases ready. And
Okay,
this
sir.
type of transmission is good, sir, for teaching.
Okay,
So
okay.
it is like a normal way they can see. Thank you,
Okay.
sir. Thank you so much.
Thank you very
Thank you,
much,
sir.
sir. Thank you, sir.
Thank you very much. Thank you, sir. Thank you. Thank you.
Thank
Thank you.
you.
சீக்கிரம் செட் பண்ணி கொண்டு போய் வேற ஓட்டி ஃப்ரீ இல்லையா சரி இங்கே செட் பண்ணு because